Welcome to the 4th annual staging of Cornwall Regional Hospital's Paediatric Symposium. We are happy that you're here today. Welcome to those of you who have been with us from day one, year one, and to those of you who are joining us for the very first time, a special welcome to you. We are mindful of the fact that there are competing events that are taking place today, Sunday, January 29th, but you chose to be here, and for that we are grateful. And we are also hopeful that you'll be encouraged by the presentations that will be taking place from our dynamic speakers to join us for future stagings of our Paediatric Symposium. Welcome, one and all.
We would like to thank you, our faithful participants, for your continued support. Through symposium funding, we have been able to acquire much needed equipment for our special care nursery. Equipment such as our laryngoscopes, Neopuff, and infusion pumps. We hope that we will be able to acquire even more life-saving equipment in the year ahead with your support for both our neonatal population as well as our pediatric population.
Our symposium has taken you from General Pediatrics 101 in our first staging to the head and neck to puberty and obesity in our last staging. This year we are tugging at your heartstrings, caring for the pediatric heart. Our expert speakers and ethics panelists promise to keep you in sinus rhythm despite exciting your neurons.
So relax, put on your favorite PJs, and let's have a heart-to-heart. Remember, jot down those questions or post them to the forum and we will get to them during that segment of the program. Enjoy today's presentation. Again, welcome.
Welcome and again, everybody. I hand you over now to our moderator for the first session, Dr. Sujavi. Dr. Sujavi, over to you.
Thanks so much. Good morning, everybody. And I'll give my welcome to everybody from Jamaica and throughout the Caribbean diaspora. I'll be your moderator for the first session. And I'd just like to preamble by saying that cardiology makes up such a large portion of the daily pediatric practice. It also is one of those disciplines that lends itself to learning and interventions at all levels. And it spans all the most junior and also the most senior individuals. So the more capable we are, the better we are at managing these little lives that we've been given the responsibility to seeing. This is an opportunity this morning for capacity building in terms of mental strength. And I'd also like to remind you guys that the cardiology practice throughout the Caribbean diaspora continues to need support. So for all those young minds that are with us this morning that are thinking about future careers, remember that cardiology still needs a great deal of support. I'd like to take the opportunity to really thank the individuals that helped us to pioneer cardiology throughout the Caribbean, throughout the University Hospital, throughout Bustamante. Notable mentions, Dr. Millard, Dr. Scott, Dr. Maurice, Dr. Oligboy recently returned to us, Dr. Forrester, and Dr. Tomlinson Morris. They're always accessible and have always been ready to teach. So with no further preamble, I'd like to welcome you guys, and I'd like to introduce our first speaker. All of us know her as Sharon, but I'll introduce her formally as Sharon Forrester. So she obtained her 2 undergraduate degrees a bachelor's in science with first-class honors in mathematics and chemistry, and a Bachelor of Medicine and Surgery, MBBS, at the University of the West Indies, Mona. Her postgraduate degree was also at the University of the West Indies, and she obtained her Doctor of Medicine in Pediatrics in 2007. She subsequently went on to do a 2-year fellowship in pediatric cardiology at the Royal Brompton Hospital in London, England. She currently works in the Bustamante Hospital for Children as a consultant pediatric cardiologist. So let's open our minds, take out our cup of coffee, and get ready for this learning session on cardiac emergencies with Dr. Sharon Forrester. Over to you, Sharon.
Thank you, Dr. Sajabi, for that great introduction. And I would just like to say thank you to the organizers of the committee for inviting me to present on this topic of cardiac emergencies. I just tried it and it worked. Okay. I also want to thank Dr. Sajabi for that preamble about pediatric cardiology. Just a reminder that it's the commonest congenital defect that is going to present, and it likely presents to the pediatricians before they get to us. So being able to recognize conditions that will present with common pediatric cardiac emergencies is quite important. And that's going to be some of the things I will try to outline in this presentation. We can't go through all the underlying cardiac pathology that will cause pediatric emergencies, but I will try to go through the ones that are most common. And we'll look at some of the initial management of some of these conditions. I will not be going through the ABCs of emergency management, because whatever emergency a patient presents in, we all know about the ABCs that need to take place. Pediatric cardiac emergencies is not as common in children as it is in adults, and the presentation and cause is quite variable. It depends on the age of the child and the type of underlying lesion that the child has. In neonates and infants, congenital heart disease, be it cyanotic or acyanotic, will be the major cause of a pediatric cardiac emergency. And as the child gets older, acquired heart disease and arrhythmias tends to be the more common cause of pediatric cardiac emergency. So early recognition and management is quite important to prevent morbidity and mortality. So let us start with those in the neonatal period. Infants with severe congenital heart defects can initially be asymptomatic with a relatively benign physical exam prior to discharge. And because they're being discharged so early from the special care nurse, they look well. And this is because of the patency of the ductus arteriosus. Look here for pulse oximetry. Screening with pulse oximetry can help to detect some of these critical congenital heart defects. Now, the ductus begins to close within the first 2 weeks of life. It may take up to 6 weeks. The patients with ductal dependent lesions, which dominate the presentation in this neonatal age group, may present anywhere from the newborn period to the first 4 to 6 weeks of life. Let's just do a quick reminder about the fetal circulation. The fetus receives oxygenated blood via the umbilical vein from the placenta. And this oxygenated blood is essentially directed through the inferior vena cava, the majority of it straight across the patent foramen ovale into the left atrium, left ventricle, and out through the aorta. A small amount of that blood goes into the right ventricle and through the pulmonary artery, sorry, too early in the morning, pulmonary artery. But there's no gaseous exchange that is going on at the level at the lungs, because in the fetus, the lungs is filled with fluid, and the pulmonary vascular resistance is very high. So there's no lung exchange happening at that level. So the majority of that flow will go through the ductus into the aorta to supply the body with oxygenated blood. Now, at birth, with the release of catecholamines and hormones at delivery, there is resorption of the fluid that is within the sac in the lung. And so gaseous exchange can now happen. And so flow starts to take place within the lung. And the books will tell you that the foramen ovale starts to close off, and the ductus arteriosus starts to close off. It does take a while. And it's this closing that will cause the patients to present in dire emergencies. So let us quickly look at the cyanose neonate. Infants with heart disease dependent on ductal patency, closure of the ductus may start close after birth and leads to this neonate becoming abruptly ill due to low cardiac output or severe desaturation. They develop progressive and rapid cyanosis, not improved with oxygen administration, respiratory support. They may have respiratory distress, signs of hepatomegaly, tachycardia, and signs of poor perfusion. Now, the causes of cyanosis in the newborn is a pretty long list, yes? And we'll be dealing with this small number of causes, though quite life-threatening if intervention is not, appropriate intervention is not instituted quickly. So the history may help you. A quick idea of what happened in pregnancy that may cause important risk factors as to why this child is cyanosed. History of maternal diabetes or any dysmorphism after birth may suggest congenital heart defects, while other history may suggest other causes of cyanosis. I just want to share with you quickly 2 cases that we were involved in the management of. Case 1, a baby of SJ, quite uncomplicated pregnancy, except for in the 3rd trimester, she had an ultrasound which revealed intrauterine growth retardation. She had mother had induction of labor, and after delivery the baby was noted to have respiratory distress, grunting, and hypoxia. They started oxygen, but the hypoxia persisted at her local hospital, that is. They placed the baby on nasopharyngeal CPAP, no improvement. They went to ET CPAP, no improvement. During this time, they did a sepsis screen because they want to rule out sepsis, and antibiotics commenced. Later that day, somebody heard a murmur and wondered about a cyanotic congenital heart disease. So since there was no improvement in the saturation, they escalated back down to nasopharyngeal CPAP. On day 2, there was worsening of the respiratory distress. Baby was rescreened and antibiotics changed. Day 3 of life, baby was transferred to Bustamante. And when we did an echocardiogram, baby had a transposition of the great arteries with intact ventricular septum, small ASD and a small PD, because by now the PD has started to close. So this echo picture just shows you what transposition, as the name suggests, the pulmonary artery is now coming off the left ventricle, the aorta is now coming off the RV, mixing the aorta, the anterior vessel, and the pulmonary artery posterior. So when we made this diagnosis, we commenced the infant on prostaglandin, and the patient was admitted to our nursery. In case 2, KM was delivered at 36 plus 5 weeks. She was twin 2. She had a low birth weight of 1.87 kilograms. She was admitted to her local special care nursery due to mild respiratory distress and low Apgar. She was commenced on oxygen, and when they reviewed her 6 hours later, the respiratory distress had improved, and the oxygen was discontinued. At 24 hours of life, she was noted to be cyanosis with postductal SATs as low as 52%, and a cardiac murmur was heard. She was given a bolus of Ringer's screen, started on antibiotics. They did an ABG, which showed severe hypoxia. PO2 was 25, and respiratory acidosis. The local team started her on prostaglandin, which showed an improvement in her pre- and postductal SATs. The ABG showed improved oxygenation, PO2 now about 132, and she was transferred to us day 2 of life on prostaglandin. And her diagnosis, showed a valvular pulmonary atresia with intact ventricular septum. So there was no continuation between the right ventricle and the pulmonary valve because the pulmonary artery, because the pulmonary valve was atretic. So the only way for flow to get into the lungs was through the duct. So those are 2 examples of the many cases of the cyanosis infant that we manage at Bustamante. I say that to say maintaining the duct patency in these newborns is quite important. The prostaglandin causes vasodilation of the smooth muscle in the ductus, preventing closure. We are aware of the adverse effects that can happen from prostaglandin. One study here by Lucron found that 19% of the patients presented with apnea. Other studies will report 12%. The majority of apnea occurs, they say, within the first 12 hours of starting the medication, and usually seen in patients less than 2,000 grams in weight. We have been lucky so far that we have been able to give most of our patients prostaglandin on the open ward with close monitoring, cardiac monitoring, and monitoring for signs of apnea. You must be able to have further respiratory support available if the patient becomes apneic. And there are other adverse effects as listed there that prostaglandin can cause. So we tend to start at a dose of 0.01 mics per kilogram per minute, or 10 nanograms per kilogram per minute. And then we titrate down to as the lowest dose as possible that is required. So more and more of our pediatricians out there are in dialogue with their pharmacies and have prostaglandin in stock, and are willing to start the prostaglandin, which stabilizes these infants and make them better for transfer into us. What it does mean is that we are seeing a lot more cases of these complex anatomy who are now alive and who will need management, and they tend to require multiple surgeries, but that's for another presentation. So looking quickly at the acyanotic newborn, they may present with signs of congestive heart failure and low cardiac output, signs of cardiogenic shock, metabolic acidosis, and circulatory shutdown. But just a reminder though that newborns, when they present with shock during the first month of life, septic and hypovolemic shock continues to be the more common cause of shock in general. So you have to have a high index of suspicion to say this patient may have underlying congenital heart problems that is also causing signs of a shock. And these conditions that cause low cardiac output include congenital heart disease, especially, again, the duct-dependent ones in the neonate who have left-sided obstructive lesions. They can have cardiac muscle disorders such as cardiomyopathy, or even arrhythmias can present with shock. Please excuse the barking dog. Now, for left-sided obstructive lesions, the normal flow from the left ventricle to systemic arterial circulation is compromised because of either stenosis or complete interruption of flow. And the PDA is essential to maintaining flow to systemic circulation bypassing the area of stenosis or interruption. So when this PDA closes, the flow to the descending aorta is compromised, leading to tissue hyperperfusion and hypoxia with subsequent lactic acidosis and shock. And some of the congenital defects with left-sided obstruction, severe coarctation of the aorta, which is the most common, critical aortic stenosis, interrupted aortic arch, which is just the most severe form of coarctation, and hypoplastic left heart syndrome. These are some of the things that would present with low cardiac output. So management includes hemodynamic stabilization. As I said, you secure your airway if you need to ventilator support to reduce oxygen consumption. And you may have to start prostaglandin if you suspect that this is a left-sided obstructive lesion. I will just quickly mention coarctation because it's the most common and it's one of the ones that we can actually do something about. And the patients may be asymptomatic right after birth, again, because the PDA is helping to perfuse the lower body, irrespective of the severity of the disease, of the coarctation. And when you have severe or very critical coarctation, once that PDA starts closed, then that is when they develop signs of cardiogenic shock, and they may present initially with just tachypnea. You may feel absent or decreased femoral pulses. Once the duct is open, the pulse, there will be no change in the femoral pulses. And they can rapidly decompensate to metabolic acidosis and unresponsiveness. So if suspected and your patient is shocked, please commence prostaglandin and transfer for further management. Or if they don't reach that stage as yet and you're occurring coarctation, contact us because we know they can decompensate very quickly. Arrhythmia is another cause in the neonates that can present with hemodynamic instability, maybe a tachyarrhythmia or a bradyarrhythmia, and may be associated with a normal structure heart or an abnormal structure heart. Tachyarrhythmia is when the heart rate is greater than 250 beats per minute in neonates. And the most common symptomatic arrhythmia is a supraventricular tachycardia that is seen. Most patients are initially hemodynamically stable with their SVT, but if it is prolonged and not abated, they will present with signs of severe congestive heart failure and even in shock. So they may appear lethargic, tachypnic, fussy, signs of poor perfusion. And when you do an ECG, what you see is a narrow, complex, fast tachycardia. Management, after you have done your ABCs, when you see that, it depends on the stability of the patient. If they're stable, you may start with the vagal maneuvers. If they're unstable and you have adenosine, you give adenosine plus or minus cardioversion. At the other end of the spectrum, it's a slow heart rate. Complete heart block, though rare, can lead to congestive heart failure and occasionally to cardiovascular collapse and sudden death in these newborns. Isolated complete heart block is more commonly seen in babies born to mothers with autoimmune conditions such as SLE or Sjogren's syndrome. And the mother may not even know that she has lupus, but she may have anti-RON antibodies circling around, which crosses the placenta and that affects the fetus's conduction bundle, resulting in heart block. More rarely, you may see heart block in patients who have complex congenital heart disease, and these usually have a poor prognosis. Emergency management include pharmacological support and the placement of a pacemaker at a temporary or permanent as indicated. So quickly moving on to the older child, looking at the acyanotic lesions first.
The presentation, again, will depend on the age of the child. When the pulmonary vascular resistance begins to fall about age 4 to 6 weeks, patients who have underlying congenital defects that will result in significant left to right shunting and pulmonary congestion will tend to present at this age. And they will present typically with poor feeding, failing to thrive, respiratory distress, diaphoresis. Again, we all know about the supportive measures of fluid restriction, diuretic, and inotropic support as required. And some of the causes of these lesions, we know are congenital heart defects that present with significant left to right shunts, large ventricular septal defects or atrioventricular septal defects, or large PDAs, just to name a few. A dilated cardiomyopathy from whatever cause can also present in severe CCF. Just want to quickly mention the dilated cardiomyopathy, which is a heart muscle disease characterized by dilatation of the left ventricle and poor systolic function. Symptoms can range from being asymptomatic to having sudden cardiovascular collapse and death. In the older children, myocarditis is the commonest cause. And it usually follows some insidious, non-specific flu-like illness. So you may get a history of them having a fever and a cough prior to them coming in severe respiratory distress and collapse. They may have a fulminant presentation characterized by acute severe hemodynamic compromise with severe congestive heart failure or cardiac shock. Examination might reveal a diffuse or displaced apex beats, soft heart sound. They may have a gallop rhythm, hepatomegaly, and they may have signs of mitral regurgitation. It is a potentially fatal disease and accounts for unexpected deaths of about 75% in infants and 25% in children. So recognition and diagnosis is imperative, but may prove challenging because the clinical presentation is quite varied and can be similar to other conditions like asthma and pneumonia, because these patients can present with wheezing, what we call cardiac wheezing, but are diagnosed as asthmatics. They may present with signs and features such as of a pneumonia, because sometimes due to the pulmonary congestion, they do end up with an infection. But it's when you do the chest X-ray, you see a marked dilated heart, and on a chest X-ray that might clue you in that this patient does have underlying heart problem. In one series that I saw, the initial evaluating physician diagnosed asthma or pneumonia in more than 50% of patients who actually had myocarditis. So it's not uncommon, but if your patient is not settling or you're seeing other evidence to support a cardiac diagnosis, please refer on. And this is just, I was just showing you a picture of a dilated, poorly functioning left heart. Just quickly want to mention Al Kappa is not very common, but it does cause a dilated cardiomyopathy and presents in the same way. I just mention it because we had a newly diagnosed Al Kappa within the last 2 weeks. And Al Kappa stands for anomalous origin of the left coronary artery. It is now coming off the pulmonary trunk and not the aorta. So the areas of the left ventricle that it supplies is not getting oxygenated blood, so it will present. So the area becomes ischemic, and so the muscle becomes dilated and poorly functioning, and they present as well with signs of a dilated cardiomyopathy with decreased output. Another area of that an older child may present is with a sudden cardiac collapse. And one of the main culprits for this is a hypertrophic cardiomyopathy. Unfortunately, the cardiac arrest and the sudden death may just be the very first presentation of this condition. And this is where the muscles of the heart are quite hypertrophied. And so there is a setup for tachyarrhythmias and bradyarrhythmias to occur that would result in sudden collapse. The clinical presentation is varied, and typically in athletes aged 10 to 35 years old are the most common group to experience a cardiac arrest or a sudden cardiac death. I'm sure everybody remembers the Buffalo Bills quarterback who collapsed on the field in earlier this year. We have had examples of students collapsing suddenly on the football field, in the pool. It's usually surrounded by people, so it is usually a shocking experience and it gets a lot of news play. But luckily, it's not something that happens quite frequently. But unfortunately, this may be the way that they present. If they don't present with sudden collapse, they may present with symptoms related to poor diastolic dysfunction and preserved systolic function that include exertional chest pain, shortness of breath, palpitations, pre-syncope and syncopal episodes. The disease can progress to end-stage congestive heart failure, which is heralded by systolic dysfunction. And the patients can sometimes have atrial fibrillation associated with embolic stroke. And what these patients need is an ICD implantation to recognize the ventricular arrhythmias that they can get, and to shut them out of those rhythms that can cause sudden death. Other causes of a sudden collapse or arrhythmias can be in structurally normal hearts. They may have conduction disorders, like long QT syndrome, CPVT, all undiagnosed until that episode of sudden collapse. And management of these patients is just having prompt initiation of CPR, having defibrillators available to treat the abnormal ventricular rhythm. But unfortunately, some of this is not available at the time, and even if available, death ensues. The older child will present with acquired heart disease. I don't know if I'm going over my time, but I'm wrapping up quickly. Infectious agents can lead to endocarditis, pericarditis, and subsequent pericardial effusion are quite common in this in the older children. And pericarditis, the clinical features depend not only on the amount of fluid, but more importantly on the speed of the fluid accumulation. And the more rapid, the more likely it will cause cardiac tamponade and cardiogenic shock. Suggestive features which may suggest a patient may have a significant pericardial effusion, cordial pain. You can't feel the apex beat, the heart sounds are muffled. You may get a pericardial friction rub or knock, and you may see cardiomegaly on the chest X-ray. Signs of tamponade include tachycardia with pulsus paradoxus. And this is just a echo picture showing you this large effusion and this heart streaming in this large effusion. Collapse of the right ventricular wall is a sign of impending tamponade. Urgent decompression of the pericardial space is mandatory and life-saving. These were just a few of our patients that we had with a large collection of fluid, pericardial fluid. Heart is just swimming in this large fluid, and they had to have the fluid evacuated. Right, got it already. And lastly, I want to mention that these older children may present as an emergency with cyanosis, and the commonest is a hypocyanotic spell, where you have a acutely reduced pulmonary blood flow leading to severe hypoxemia, metabolic acidosis, and it's usually associated with a trigger. It may be the first presentation of infants and children with unrepaired tetralogy of Fallot they are presenting to you for the first time, or other cardiac defects that have similar physiology as a tetralogy. Or, unfortunately, it may be the recurrent presentation of unrepaired Fallots. So we do have quite a bit of unrepaired Fallots out there. Circumstances a lot beyond our control, who keep presenting in with a cyanotic spell, and the most that we can do is try to and hope that we can get them out of the spell as they await their intervention. The spell can be self-limiting, but may lead to serious complications, syncope, seizure-like episodes, and even death. So a TED spell, be it in a newly diagnosed Fallot or an unrepaired Fallot, is an emergency. We all know about the management, so I'm not going to go through this. Knee to chest position. You try to keep the child as calm as possible. You can give oxygen. It's not really going to help much, but if the oxygen mask is causing the child to be agitated, take it off. Your bolus, correct your metabolic acidosis, morphine to try and sedate the child, propranolol to reduce the infundibulous spasm, and you may have to give phenylephrine to increase the systemic vascular resistance. So hopefully, I have outlined that the causes of pediatric cardiac emergencies are many and complex, and I, in the interest of time, did not go through all the other wonderful complex congenital defects that can present with as a cardiac emergency, or the patients who are known to have underlying complex disease and who require multiple surgeries and are in between stages of their surgeries. They also can present with cardiac emergencies. The diagnosis, as mentioned, is not always straightforward. They may look and present like a sepsis. You may think this is an asthmatic child. But so you have to have a high index of suspicion so that you can institute the appropriate plan of management to stabilize the patient and refer on to specialist care where appropriate. Those are my references. Thank you very much.
All right, Sharon, that was excellent. That was really good. So in the interest of time, I see that some questions have been posted in the question and answer area. What's going to happen is that we're going to discuss those questions later on in the session. You'll see that on the itinerary, after both presenters are completed, we'll go through those questions. So I'd like you to continue to post. I see that we have up to 619 participants, and I'd like you all to invite everybody. We need to get to 1,000 to today. So everybody that's still in their beds, anybody that would have intended to be with us this morning, run along. It's still possible to join us. All right. So with no further ado, I think we're going to run forward to get ready for our second presenter. And I'd like to introduce you guys to a young lady named Dr. Tamara Tomlinson Morris. So this young person is a consultant in the Department of Medicine and the Division of Pediatric Cardiology at the Bustamante Hospital for Children. She's a graduate of the University of the West Indies and completed a fellowship in pediatric cardiology at the renowned Royal Brompton Hospital in London. She has expertise in the management of acute and chronic pediatric cardiology in a resource challenged setting and has interest especially in electrophysiology. Dr. Tomlinson is a former associate lecturer in the pediatric department at the University of the West Indies and is a past president of the Paediatric Association of Jamaica. And I must say, most importantly, after all of that, she's married with 2 sons. So, round of applause for Tamra. Please take it away. Go for it. Wow, guys. Okay, that was excellent. Thank you so much, Tamra. I think I speak for all of us on the platform that flowed really well, and it was a welcome reminder in some instances, and then in other instances, it was a great opportunity to see some new events. All right, so there are questions and answers, but we are actually running a little bit late. What I'd like to do is I'm going to ask the presenters, both Dr. Forrester and Dr. Morris, to answer as many of the questions in the Q&A electronically. So just type for me, so that we can move along speedily. All right. So I'd like to thank these 2 presenters. That was really, really good from both of you. Remember that this is an opportunity for us to learn and relearn. This is an opportunity for us to try to inspire and to try to get individuals that would have ambiguities or questions about cardiology, and also to get the individuals that eventually want to concentrate entirely on cardiology interested. Inspiration. All right. So at this time, we're going to move forward with the next part of the presentation, and I'll hand you over to our next panelist. Well, our next moderator, I should say. So this would have been my morning session. So thanks, guys, for sharing with me. And I'll still be here listening and learning as well. All right, guys, farewell.
Welcome to the world of Indus, and we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux, and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. NewGel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimethicone in NewGel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimethicone thus relieves flatulence. NewGel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. NewGel is available as NewGel 200 ml suspension and NewGel tablets with delicious mint flavor. NewGel is safe in pregnancy. NewGel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents NewGel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. NewGel O is available in 200 ml suspension with mint flavor. NewGel and NewGel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
Hi, good morning. So our previous presenters would have been posed, questions would have been posed to them, but they were unable to answer at the time. So I'm just going to ask a few of them directed to Doctors Tamra Tomlinson Morris and Dr. Forrester. So the first question, left hypoplastic heart, is it present with mostly cyanotic or acyanotic presentation? Is it a cyanotic or acyanotic presentation? Dr. Forrester, that would be you. You're muted. Muted.
The majority of the presentations are as cyanotic conditions, but you have to remember that hypoplastic left heart, there's a spectrum, and the more severe end of the spectrum will present with cyanosis. So it may just involve this mitral atresia alone and a small LV, but you may have a large VSD and the aorta is coming off the right ventricle. So that person may not present with a lot of cyanosis. Going down the spectrum, you may have mitral atresia, you may have a stenotic aortic valve and hypoplastic aorta. And to the further end of the spectrum where you have mitral atresia, aortic valve atresia, very small non-functional left ventricle, and a single ventricle, which is your right ventricle. So depending on where on the spectrum of a hypoplastic left heart will determine how the patient presents. So it may be acyanotic. If it's on the milder end of the spectrum, the more severe end of the spectrum, they will present cyanosis. And we do get those patients as well.
Thank you. The next question, also directed at Dr. Forrester. In an adolescent athlete with repeated episodes of near syncope on exertion and a normal cardiac exam and normal ECG and echo, what further investigations, if any, would you suggest? And what recommendations would you make?
The syncope is happening on exertion. That was the question.
It says repeated episodes of near syncope on exertion. Yes.
Well, that's a red flag. Even if the initial cardiac evaluation, your ECG, echocardiogram are normal, which can happen, the fact that this patient is having syncopal or near syncopal episodes on exertion raises a red flag. So we would hold all physical activity while we do further investigations. Depending on the frequency of the symptoms, we may want to do a 24-hour Holter, 24 or 48-hour Holter to see if we can pick up any arrhythmias that we are not seeing on the resting ECG. You may want to do a stress test for this patient under a controlled environment, stress ECG, stress echocardiogram, so to see if you can pick up any abnormalities while the patient is exerting himself or herself, that would indicate why this patient is having syncope during activity. So I would go next to do those investigations to determine whether or not there's an underlying cardiac pathology resulting in the presentation.
Okay, thank you. And the final question, Dr. Kernan, many of our patients are asthmatic and many are poorly controlled and present frequently. What should lead me to suspect a particular child needs referral for cardiac evaluation? So poorly controlled asthmatic.
Well, your history is going to be important here. Your history and examination, because if this is a history with a child who is known to have other family members who have asthma or atopy, the child has other atopical symptoms, rhinitis, sinusitis, eczema, then quite likely this child is having the
has bronchial asthma. If you hear a cardiac murmur, that would be an indication to refer for further investigation, depending on what your chest X-ray shows as well. Because if your chest X-ray shows increased cardiac silhouette, increased pulmonary vascular markings, then again, that's another indication to refer your patient for further evaluation. The take-home point is that not all wheezing is due to bronchial asthma, and we just need to bear that in the back of our minds. So if your history is not suggestive of a child who has atopy and bronchial asthma, then widen your differential diagnosis.
Great, thank you very much. I think Dr. Tamra, you had answered your questions online. So thank you both for presenting, and then we'll now proceed. Thank you.
You're welcome.
Okay, good morning, everyone. I hope you're hearing me. Welcome
Good
to
morning.
the second session.
No, good morning. Yes, we're hearing you. Go ahead, please.
Okay. Wonderful. Good morning, everyone. Welcome to those who have joined us a little late. We're running a little bit behind time, but no worries. We will get everything in. Thank you to the organizers for inviting me to be a moderator on this most prestigious symposium, and congratulations on your 4th annual Cornwall Regional Hospital Paediatric Symposium. By the number of persons that I see currently online, we're almost at 700 persons. Clearly, everyone agrees that the quality of your conferences over the years have been excellent, and everyone is eager and raring to go. So let us jump right into it. And first out of the blocks, we have our keynote presenter, Dr. Juanita Hunter, and I will tell you a little bit about her. Dr. Juanita Hunter obtained her medical degree at the University of the West Indies, Mona campus in 2006. She subsequently completed a residency in general pediatrics and fellowship training in pediatric cardiology at the Holtz Children's Jackson Memorial Hospital, graduating in 2015. She has since held a faculty position at the University of Miami as assistant professor in the Division of Pediatric Cardiology, where her responsibilities include clinical care, teaching, and research. Her expertise includes managing infants, children, adolescents, and adults with congenital and acquired heart disease in the outpatient clinic, inpatient wards, and in the intensive care unit. She's also a member of the Pediatric Cardiology Non-Invasive Imaging Laboratory, where she performs and interprets thoracic, transesophageal, and fetal echocardiograms. Dr. Hunter is passionate about teaching and participates regularly in the education of students, residents, fellows, and support staff. It is her hope that through this lecture, you will have learned a little bit more and been motivated to improve the care provided to children with congenital heart disease. So we welcome Dr. Juanita Hunter, who will present neonatal critical cardiac lesions and arrhythmias. Over to you, Dr. Hunter. Nice to see you.
So good morning. Thank you all for inviting me to participate in this conference. It gives me great pleasure, and I consider it an honor and a privilege to be presenting alongside my colleagues and mentors. It has always been a desire of mine to maintain and even strengthen the relationships with our colleagues back home in Jamaica. And so when Dr. Henny Harry reached out to me to participate in this conference, in a heartbeat, I was willing to join and to become part of the team. So thank you again, and I look forward to other such opportunities for collaboration in the future. So let's get to it, because Dr. Henny Harry has given me, or the team that has organized the conference has given me the great feat of covering 2 major topics in the field of pediatric cardiology, all in the space of 30 minutes. So we'll jump right in. So first, to disclose, I have no conflicts of interest. And then in this presentation, at the end, you should be able to describe the approach to managing the neonate with suspected critical congenital heart disease, outline the screening algorithm for detecting neonates with critical congenital heart disease, recognize common arrhythmias presenting in the neonatal period, and describe the approach towards managing arrhythmias in the neonate. Or babies who are born with congenital heart disease, as we all remember from embryology and embryogenesis, the disease begins much earlier in the gestation. And so I just wanted to touch on a few features of the fetal circulation that are important to the infant, to the neonate who has congenital heart disease. So just some unique features of the fetal circulation. The placenta is part of the fetal circulation that's unique to the fetus and not to the neonate. It's a very low resistance circuit, and we'll talk about the significance of that in a moment. The fetal circulation also includes the umbilical vessels consisting of 2 arteries and 1 vein. And, we'll remember from medical school and, through our residency as well, the umbilical vein is the vein in the fetus that has the highest oxygen saturation. In fact, the vessel in the fetus that has the highest oxygen saturation. The ductus venosus is also unique to the circulation, the foramen ovale and the ductus arteriosus. The lower body and abdominal viscera receive blood at a lower partial pressure of oxygen in the fetus compared to the neonate, and that's because of the obligatory right to left shunting across the ductus from the pulmonary artery to the aorta in the fetus. The fetus is able to tolerate the hypoxemic environment due to its reduced metabolic demand and increased red cell mass. And the systemic circulation, as I mentioned before, is a low resistance circuit because of the connection to the placental circulation. The pulmonary vascular bed, in contrast, is a high resistance circuit in utero, and the right ventricle performs most of the work in the fetus, managing approximately 60 to 70% of the combined cardiac output. And so the right ventricular cavity, especially in later gestation, tends to be more prominent or even larger than the left ventricular cavity. And the left ventricle manages up to 30% of the cardiac output. So once a baby is born, in that transitional period, when the baby takes his or her first breath, the pulmonary vascular resistance decreases dramatically. When the umbilical cord is clamped and the placenta is removed, the systemic vascular resistance increases and the work of the left heart also increases. There's an increase in left atrial pressure related to increased pulmonary venous return to the left atrium and the increased end-diastolic pressure of the left ventricle, and this leads to closure of the foramen ovale. At the ductal level, because of the fall in pulmonary vascular resistance and the increase in systemic vascular resistance, there's left to right shunting, and the increase in partial pressure of oxygen that the ductus is exposed to at this time leads to functional closure initially and then subsequently anatomical closure. There is an increase in the cardiac output from the left ventricle, and the circulations become circulations in series rather than in parallel, with both ventricles managing the same cardiac output. So let's talk about neonatal critical cardiac lesions. So we're learning, especially nowadays when discussing topics in cardiology, it may be a bit easier to use a case-based approach. So our first case, you're called to assess a male newborn, 39 weeks gestation, born to a mom who is 21 years old. This is her 5th pregnancy. She has 3 children living, and she received no prenatal care. The infant was born via spontaneous vaginal delivery with a birth weight of 3 kilograms and APGAR scores of 8 at 1 and 5 minutes respectively, with 2 points lost each for color. The infant is given oxygen in the delivery room, including CPAP, because of desaturations, as the saturations were persistently in the 60s, including delivery of 100% FiO2. The infant is intubated and continues to have oxygen saturations of 60s in 100% oxygen. And on exam, you notice a cyanotic neonate who is mildly tachypnic with no dysmorphisms. The precordium is active with normal volume pulses in all extremities and no brachifemoral delay. And on auscultation, there is a normal S1, a single S2, and a positive gallop. No murmur or click is heard. The lungs are clear bilaterally, and the abdomen, the liver edge palpable 2 centimeters below the right costal margin. The neonate moves all limbs equally and is reactive, and he's cyanotic in the extremities with no peripheral edema. The initial ABG has a pH of 7.24 with a PCO2 of 64, a PO2 of 33, bicarb of 27, and a base deficit of 0. And repeating 15 minutes later, having received 100% oxygen, again continues with an acidosis with a pH of 7.28, a PCO2 of 52, a PO2 of 24, bicarb of 24, and a base deficit of -3. So mostly a respiratory acidosis there. But just some of the key things. So this mother received no prenatal care. You have no idea as to what the cardiac anatomy was in utero, you know, whether she did an anomaly scan at 18 to 20 weeks to pick up abnormalities. So you don't have the benefit of information during the antenatal period. And despite the administration of oxygen at 100% FiO2, this neonate is persistently cyanotic with saturations in the 60s. Okay, the precordium is active, has a single second heart sound, an S3 gallop, hepatomegaly. And again, despite being on 100% oxygen, the PaO2 fails to increase and actually, you know, remains, it even falls a little bit, having been on the oxygen. Okay. So what's your differential diagnosis? You're thinking that this child probably has cyanotic congenital heart disease, especially given the lack of response to the PaO2 in the presence of 100% FiO2. Okay, usually with pulmonary disease, we would expect a more significant improvement in the PaO2 on administering oxygen, but we know that with cyanotic congenital heart disease, the PaO2 fails to increase above 100 millimeters of mercury, and definitely with some form of cyanotic congenital heart disease, the PaO2 would not increase above 60, okay, and may persist in the 30s, as with the case that we just saw. So what's your differential diagnosis? As we went through medical school, you know, we always spoke about the 5 T's, but just to summarize again, okay, one possibility is transposition of the great arteries, you know, complete transposition where the aorta arises exclusively from the right ventricle and the pulmonary artery from the left ventricle, such that you have a circulation in parallel rather than in series, and deoxygenated blood from the body returns to the body. In this circulation, life is only possible if there are communications between both systems, ideally at the atrial level, in order to allow for mixing between both circulations and passage of oxygenated blood into the right atrium, right ventricle, and into the body. A PDA is often present as well, but mixing occurs best at the atrial level. Okay. Usually these patients are cyanotic, but comfortably tachypnic. And in transposition, there's also a failure of that increasing PaO2 in response to administering 100% FiO2, the so-called hyperoxia test. All right. If one was to do an X-ray, we would see the classic Egon strain sign in patients who have transposition of the great artery. So that's a consideration. Is it tetralogy of Fallot? I would go further to say perhaps tetralogy of Fallot with pulmonary atresia. With classic tetralogy of Fallot pulmonary stenosis, once there's antegrade flow across the right ventricular outflow tract, because of the pulmonary stenosis, even early on when the pulmonary vascular resistance is high, you may hear at least a murmur because of the turbulence there. Sure, the murmur becomes more pronounced as the pulmonary vascular resistance falls further, but given the stenotic right ventricular outflow tract, oftentimes you hear a murmur early in the life of the baby. But it could be run-of-the-mill tetralogy pulmonary stenosis, but with such profound cyanosis, I will go further to say perhaps tetralogy with pulmonary atresia. Okay. And then you would expect to see the boot-shaped heart with oligemic lung fields in that regard. Is this tricuspid atresia? Now, as we know, tricuspid atresia, the physiology of presentation is going to be dependent on the great artery relationship to the ventricles. So is it, classic tricuspid atresia with normally related great arteries with the aorta arising from the LV, the pulmonary artery arising from the hypoplastic right ventricle, and with restriction at this ventricular septal defect, or we like to call the bubble ventricular foramen, there may be varying degrees of limitations of pulmonary blood flow, both at the subvalvular level and at the valvular and supravalvular level, depending on the degree of development of the pulmonary arteries. Okay, so for the baby to present with profound cyanosis, this baby would need to have severe pulmonary stenosis or pulmonary atresia within the context of tricuspid atresia, because this represents a baby who has either insufficient pulmonary blood flow or inadequate mixing. The pulmonary venous return is unable to get to the systemic circulation. Another possibility is truncus arteriosus, the arterial trunk. Okay, so failure of septation of the pulmonary artery from the aorta, such that there is a single arterial trunk arising from the heart, usually associated with a ventricular septal defect, and this single semilunar valve overrides the crest of the ventricular septum. Very early after leaving the heart, the branch pulmonary arteries arise from this common arterial trunk, which then continues as the aorta. Okay, adductus is not usually present in this disease as the pulmonary arteries arise directly from the ascending arterial trunk. But these patients, in addition to cyanosis, oftentimes have tachypnea related to increased pulmonary blood flow and may have varying degrees of ventricular dysfunction depending on the coronary artery relationship to where the pulmonary arteries arise. So heart failure is usually the manifestation in this particular group of patients, cyanosis as well as heart failure, with the heart failure progressively worsening, the older the infant is. And by older the infant, I mean, yes, still a neonate, but within the first weeks of life as the pulmonary vascular resistance falls, related to increased pulmonary blood flow, increased work of the ventricles with potential coronary steal and ventricular ischemia with dysfunction. Okay. They're not usually as cyanotic unless there's, again, a problem with the pulmonary blood flow, the pulmonary arteries. Is this a patient with total anomalous pulmonary venous return? We may remember from our review that total anomalous pulmonary venous return occurs in various types. You have the supracardiac type, okay? There is the cardiac type where all the veins drain to the right atrium. There is the infracardiac type and then mixed types, all right? So because the pulmonary veins are draining into the systemic circulation, these patients will have, they will be desaturated. If there is obstruction of the pulmonary venous return, they may be significantly cyanotic, but especially when there is obstruction, these babies they would have significant respiratory distress. And on the X-ray, they may appear hazy and almost look like a respiratory distress syndrome type of picture, except that, in a term neonate who presents with profound cyanosis and significant haziness of both lung fields, this has to be a consideration. This is a true emergency in the field of pediatric cardiology, as no medication, no medical therapy is going to improve the course of these patients. If there is obstructed total anomalous pulmonary venous return, the treatment is emergency surgery. Okay. And then we have other complex forms of cyanotic congenital heart disease as well. Patients with hypoplastic left heart syndrome, complex double outlet right ventricles, Epstein anomaly, which can also be associated with functional or anatomical pulmonary atresia. This is the ECG for our patient. You'll notice the patient has very tall P waves, okay, so more than 2.5 millimeters in keeping with right atrial enlargement, and has a QR pattern here in V1 in keeping with right ventricular hypertrophy. And on the X-ray, the heart not significantly enlarged, but the pulmonary vascular markings are prominent here, particularly in the perihilar area, suspicious for pulmonary venous congestion, with the lungs a bit hazy. And I would think here the mediastinum appears normal. In case you're thinking, is this a transposition? We would expect a more narrow mediastinum. So a cardiology consult was obtained and an echocardiogram performed. And on this apical sweep, we can see that we only see one ventricle, a single ventricle, right? The left atrium is small and the atrial septum is bowing into the right atrium. There's no discernible mitral valve or left ventricular cavity. This patient has hypoplastic left heart syndrome with mitral atresia and aortic atresia and has an intact atrial septum such that the pulmonary venous return is unable to egress into the right atrium and into the right ventricle and thus to the pulmonary artery. And you'll notice posteriorly here, the pulmonary veins are prominent because that they're engorged and they're decompressing veins posteriorly, which we saw in other imaging, okay? Hence explaining this patient's profound cyanosis. And then the single second heart sound was noted because this patient has aortic valve atresia. So hypoplastic left heart syndrome is a spectrum of disease, okay? For patients who have mitral stenosis and aortic stenosis, mitral stenosis and aortic atresia, and mitral atresia and aortic atresia are the three main subtypes that we like to put, or we like to group our patients in, okay? With the mitral stenosis aortic atresia group having particularly poor outcomes related to the presence of coronary sinusoids or coronary fistula, because these put the patient at risk for ventricular ischemia and arrhythmias and sudden death. Okay. The initial management of the patient, prostaglandin infusion to maintain ductal patency in order to provide systemic perfusion. With this patient's physiology, because this is a patient with a single ventricle, this single ventricle is going to be committed to providing the systemic perfusion. And so the balance of systemic and pulmonary circulations becomes very important in this patient who has systemic outflow obstruction. Aortic atresia is associated with severe hypoplasia, usually of the ascending aorta, transverse arch, as well as coarctation of the aorta. And so this patient is ductal dependent for maintaining systemic perfusion. Oftentimes in the stabilization period, as which this patient will need to be stabilized, the patient is intubated and there are maneuvers in order to manipulate the pulmonary vascular resistance in order to promote systemic blood flow, okay, such as maintaining hypercapnia by paralyzing the patient and hypoventilating, using medications to reduce the systemic vascular resistance in order to maintain systemic perfusion, okay? And ultimately, this patient will require interventions in order to ensure that there is unobstructed pulmonary venous return to the systemic circulation. And this single ventricle is committed to the systemic circulation, and we'll find other means by which the lungs can receive blood flow. Okay, so the single ventricle palliation in this particular group of patients often involves the first stage, a Norwood procedure, which we see here, and I'll go through the surgeries in the next slide in a little bit more detail as well, where the pulmonary artery is divided from the heart and the ascending aorta anastomosed to the main pulmonary artery. The rest of the aortic arch is augmented using a homograph patch usually, so that when the right ventricle pumps, it now pumps to the aorta and there's unobstructed systemic blood flow. In order to provide pulmonary blood flow, a modified BTT shunt is placed with a Gore-Tex tubing between the innominate and the branch pulmonary artery, or with a Sano modification with a conduit from the right ventricle to the pulmonary arteries. And the atrial septum is resected in this operation in order to ensure that there's unobstructed pulmonary venous return to the right atrium, and thus to the right ventricle, which is now the systemic ventricle. Okay. Some centers prefer not to perform the Norwood as it's a major undertaking in the neonate, often involving prolonged bypass time in order to protect the neonatal brain, and may choose to do a hybrid procedure. Some may choose to do a hybrid because the neonate may have other comorbidities that may put at higher risk for cardiopulmonary bypass and a Norwood procedure. And I'll show a slide in a moment to highlight what the hybrid procedure entails. And then the second stage involves doing a Glenn at 3 to 6 months and then subsequently a Fontan. And these are all palliative surgeries. I say that because, ultimately, this is a single right ventricle, which will fail over time. So just to go through the surgical interventions, again, in the neonatal period, the Norwood, this is a classic Norwood with, extended arch reconstruction here, a BT shunt, atrial septal resection in order to ensure that there is unobstructed pulmonary venous return to the right atrium and unobstructed systemic blood flow. And then the shunt will provide a restricted source of pulmonary blood flow. Maintaining the balance of pulmonary to systemic circulation, QP to QS, continues to be important in these patients. And those who have a BT shunt, they're a unique group in that the BT shunt, because there is antegrade flow into the pulmonary vascular bed during diastole related to the low pulmonary vascular resistance, there may be a lower diastolic pressure in the aorta and therefore lower diastolic perfusion pressure for the coronaries. And the ascending aorta is often very hypoplastic, only a few millimeters, sometimes as little as 2 millimeters or less. So the diastolic perfusion pressure of the coronaries is very important in order to maintain the ventricular function. But centers that do the classic Norwood all the time have good success rates with those. One may do a hybrid instead of doing the Norwood as the first stage, whereby the patent ductus arteriosus is stented in order to maintain patency. Bands are placed on both branch pulmonary arteries to create a restriction to pulmonary blood flow there. And the atrial septum, a balloon septostomy or a stent is placed across the atrial septum by transcatheter means in order to ensure that there's unobstructed pulmonary venous return to the right heart. Okay, so the ductal stenting and the balloon septostomy are the transcatheter interventions, and then the surgeon places the pulmonary artery bands. As the second stage, at 3 to 6 months of age, usually a Glenn is performed, whereby the SVC is connected directly to the pulmonary arteries. And then later on, when the patient is, at our center, we do 3 to 4 years of age, but anywhere from 18 months to 4 years, the Fontan completion, where the IVC is directed to the pulmonary arteries via a conduit or lateral tunnel. Okay. Again, these surgeries are palliative and not curative. The right ventricle was never designed to be the systemic ventricle, and so fails over time. And so long-term complications of patients with, hypoplastic left heart syndrome and a Fontan circulation include ventricular dysfunction with heart failure, thromboembolism related to the stasis in the Fontan circulation, the flow from the SVC and IVC is draining passively to the pulmonary vascular bed. Because of the increased systemic venous pressures and increased lymphatic pressures, it plays a role in the pathophysiology of protein losing enteropathy and plastic bronchitis, which are chronic long-term complications of patients who have Fontan, and are reasons why these patients are referred for transplant ultimately. Okay, at best, the survival in recent series has been described to be anywhere between 70 and 80% at 20 years, with certain subtypes of hypoplastic left heart having a poorer survival. And a recent series from the UK reported that, they had a survival of 40% at 15 years. So our patient was started on prostaglandin infusion and underwent emergent transcatheter intervention with radiofrequency ablation of the atrial septum and placement of an atrial stent. He subsequently underwent a hybrid procedure, but his course was complicated by cardiac arrest at around 2 months of age. And then, another transcatheter procedure was performed in order to ensure that there was unobstructed flow across the ductal stent. So he got a second ductal stent. And underwent ultimately a comprehensive stage 2 with the Norwood and Glenn at about 3 months of age. His course was further complicated by ventricular dysfunction and recurrent restriction at the atrial septum, for which he required surgery again at around 10 months of age, and was found to have pulmonary hypertension and a cardiac catheterization performed prior to his atrial septal resection and in follow-ups thereafter, and was started on pulmonary vasodilator therapy. And while preparing to work him up for a transplant, unfortunately, he demised at 3 years of age suddenly in his sleep. The second case is a 3-week-old born at term gestation in a birthing center who presents to the pediatrician for a well visit. He was found to be cyanotic in the office with oxygen saturations in the 40s and transferred emergently to the emergency room. While in the ED, he was given oxygen with no response, was intubated, and the saturation persisted in the 40s to 60s range. The initial blood gas showed a pH of 7.21, PCO2 of 42, PaO2 of 33, bicarb of 17, and a base deficit of -11, so profound metabolic acidosis. And thereafter, following administration of oxygen, again, the pH, oxygen, as well as, I'm sure this patient also received bicarbonate infusion for correction of the acidosis. pH improved to 7.46, PCO2 44, but the PaO2 remained low at 21, and the base deficit was improved with administration of bicarb. The ECG again showed right atrial enlargement and right ventricular hypertrophy. And if you look to the right, the chest X-ray shows, cardiomegaly, this globular heart, and the mediastinum is narrow, and there are increased pulmonary vascular markings. So this would be your so-called egg on string appearance of the heart with a narrow mediastinum and this globular heart. An echocardiogram was performed, just to throw this in there for cardiology colleagues, and for those who aspire to be pediatric cardiologists in the future. So this is the parasternal long axis view. We have the left atrium here, mitral valve, left ventricle, and the left ventricular outflow tract. And in this view, we can see that the left ventricle is oriented to the main pulmonary artery. And know that this is the main pulmonary artery because I can see a branched pulmonary artery here, and this red flow coming in is actually flow from the ductus arteriosus. More anteriorly, this is the right ventricle, which is oriented to the aorta. And this is one of the views that we use as classic for diagnosing transposition, as both great arteries arise in parallel, as opposed to the usual crossing of the great arteries in different planes. Okay. Due to this patient's profound hypoxia, and supported by the fact that on his imaging, he had a restrictive atrial communication. He underwent balloon atrial septostomy. So we see here to the right, the balloon being inflated in the left atrium and then being jerked across the atrial septum into the right atrium in order to enlarge that atrial communication, encourage atrial level mixing, and improve the saturations in this patient. Okay. So transposition of the great arteries. Existing anatomic variations, the more simpler form being transposition with intact ventricular septum, but can also occur with ventricular septal defect, pulmonary stenosis, and coarctation, and more complex forms of transposition. The coronary artery pattern is important for us to note as it impacts the surgical approach and outcomes, as well as whether or not there is commissural alignment, just in terms of the surgical technique. We use prostaglandins during stabilization, but mixing occurs best at the atrial level. And so if these patients are hypoxic, they need a balloon atrial septostomy. Okay, the treatment of choice is an arterial switch operation, usually in the first week of life. Once we start to wait, beyond a couple of weeks, then we run the risk of the left ventricle becoming deconditioned, but outcomes are better with earlier repair. And long-term complications of transposition repair, the arterial switch include branch pulmonary artery stenosis related to the Lecomte maneuver when the pulmonary arteries are pulled anteriorly, coronary stenosis, which can occur in the coronary transfer during the arterial switch, neo-aortic root dilatation, as that neo-aortic root was originally a pulmonary root, which is not as muscular as the aorta and is prone to dilating, and the valve is also prone to leaking. So neo-aortic valve insufficiency is one of the long-term complications that we monitor for. But the outcomes are excellent, with overall survival approaching 97% at 25 years. Of course, patients with more complex forms of transposition, as this is the Taussig big anomaly associated with a pulmonary VSD and pulmonary stenosis. And also, has been described, the classic Taussig being with subaortic obstruction and coarctation. Those who have more complex forms of transposition have poorer outcomes as expected. But just straightforward transposition with intact ventricular septum, the outcomes are excellent. Okay. So, critical congenital heart disease. Is heart disease requiring intervention in the first month of life? The American Academy of Pediatrics actually extend that to the first year of life. And also I like this definition is congenital heart disease in which delayed diagnosis leads to death or injury. It includes ductal dependent lesions. So remember, the ductus is a connection between the pulmonary artery and the aorta. And so ductal dependent lesions are ductal dependent for systemic, as in the case of systemic outflow obstruction, or pulmonary blood flow, as in the case of pulmonary outflow obstruction. Okay. It also includes detransposition of the great arteries, obstructed total anomalous pulmonary venous return, especially the obstructed type, truncus arteriosus, Epstein anomaly, and complex forms of congenital heart disease, such as those with single ventricle physiology. In the X-ray here to the right, I wish it was a little bit more interactive, this conference. I would ask the group, what's the diagnosis, but this is a pathognomonic X-ray finding here. This is a patient with severe Epstein anomaly who we had recently, and you see the wall-to-wall cardiac silhouette here, the wall-to-wall heart, which is classic for severe Epstein. Okay, so or ductal dependent lesions may be ductal dependent for systemic blood flow, such as with critical aortic valve stenosis, coarctation of the aorta, or aortic arch interruption. Also, hypoplastic left heart syndrome, where you have varying degrees of left heart hypoplasia with mitral stenosis or atresia, aortic stenosis or atresia, often with arch hypoplasia and coarctation, or ductal dependent for pulmonary blood flow, such as with critical pulmonary valve stenosis, or in the setting of pulmonary atresia with a VSD or so-called tetralogy pulmonary atresia, or pulmonary atresia intact ventricular septum. And here to the right, these echo clips, and forgive me because I tend to be biased towards echo because I enjoy echo and I spend a lot of time in the echo lab performing and interpreting echoes. That's the reason why you're seeing so many echo clips in this presentation. But here at the top image, you can see that this is a suprasternal notch looking at the aortic arch, and the aortic arch continues here after the second branch. Okay, actually after the third branch. So you see there is no isthmus that joins to the descending aorta. It continues following this branch here. And the descending aorta is actually supplied more distally via the ductus arteriosus. So this is a patient who has an interrupted aortic arch, all right? And then in the image here below, this is a patient who has pulmonary valve atresia and the branch pulmonary arteries are being supplied by a ductus arteriosus. This is a patient who has tetralogy with pulmonary atresia with confluent branch P's being supplied by a ductus. So in 2011, the American Academy of Pediatrics and Human Health Services here in the United States decided to implement the critical congenital heart disease screen for all newborns born who are in nurseries and intermediate care nurseries in an attempt to identify neonates early on before they become symptomatic who have critical congenital heart disease and improve the outcomes. So this screen, the recommendation is that it be performed between 24 and 48 hours of life. You want to perform it as close to discharge as possible. If the patient needs to be discharged before 24 hours, then it's performed as close to the timing of discharge. Okay. A positive screen is where there's desaturation below 90% in the right hand or the foot. And the negative screen is where the saturation is more than 95% in the right hand or foot. And there's less than a 3% difference between the right hand and foot, okay? In between, when the saturation is between 90 to 95% in either hand or foot, or there is a more than 3% difference, the screen is repeated after an hour. If this persists, it's repeating it again after an hour. And if the screen is still abnormal in this range, it's considered a positive screen and the patient requires investigation for critical congenital heart disease, okay? If during this time, the saturations improve to above 95% and there's less than a 3% difference between the right hand and foot, then it's considered a negative screen. The infant is treated normally. And then of course, if at any time the saturation is less than 90%, that warrants further investigation. So in terms of general outcomes, it's dependent on the primary lesion, okay? And within that lesion, the anatomical subtype and spectrum of severity, okay? And generally, factors which contribute to poorer outcomes in patients with critical congenital heart disease include prematurity or low birth weight, genetic or chromosomal, disorders, and extracardiac abnormalities. Okay, jumping into the next topic quickly, and we'll run through arrhythmias in the neonate. So arrhythmias affect anywhere between 1% and 5% of neonates in the first 10 days of life. And the most common arrhythmia that we observe are ectopic beats, with premature atrial contractions being the most common, okay? In terms of tachyarrhythmias, supraventricular tachycardia is the most common tachyarrhythmia, and most arrhythmias in the neonatal period carry very good prognosis. All right, so premature atrial complexes are common in the fetus and in the neonate. We get a lot of referrals for fetus with arrhythmia for fetal echo, and when we do the fetal echo, we can, based on the M mode pattern, we can see that the fetus is having PACs. They may be conducted or blocked, and they're not usually associated with congenital heart disease. If there's any finding that's associated, it's usually an aneurysmal septum primum, but not usually associated with significant congenital heart disease. And they portend a good prognosis, usually resolving spontaneously without intervention. And this EKG, you can see here, the premature atrial contractions, okay? Premature ventricular complexes are not as common as PACs, and not as benign. They can be benign, but usually when we see them, we have to make sure that there's no myocardial pathology. They may be associated with cardiomyopathy, cardiac tumors, electrolyte derangements, metabolic disease, or inflammatory heart disease such as myocarditis. But usually isolated PVCs have a good prognosis and spontaneously resolve. So for PACs, we may not be as aggressive about performing an echo, but definitely for PVCs, we'll ensure that we perform an echo to make sure there's no myocardial disease. Rhabdomyomas can present like this as well. So the bradyarrhythmias may be related to heart block, okay? So we learned about first degree, second degree, and third degree heart block. First degree being prolongation of the PR interval. Second degree may be divided into Mobitz type 1 and Mobitz type 2, okay? Depending on the pattern of conduction from the atrium to the ventricle. So with progressive PR prolongation and a drop beat, that's classic for Mobitz type 1 or Wenckebach heart block. And we can see this even in patients with high vagal tone under normal circumstances, not usually in the neonates, but in older children, we see this commonly as a normal variant. But Mobitz type 2 is never normal. And this occurs, with conduction system disease, and you have randomly dropped beats with no evidence of PR prolongation. It's usually ominous, and most patients end up wearing a pacemaker. And then of course, third degree where there's no conduction from the atrium to the ventricle. Okay. In terms of the etiology, heart block may be associated with congenital heart disease. For example, patients with heterotaxy syndromes, particularly the polysplania or left atrial isomerism type, where the patient may have phenotypically bilateral left atrial. The conduction system is a right atrial structure, the sinus node and AV node. And so when a patient has two anatomic left atria, which can happen in these complex forms of congenital heart disease, you can also have conduction abnormalities, including bradycardia, sinus node dysfunction, and heart block, okay? Or L transposition of the great arteries, so that's congenitally corrected transposition of the great arteries, may also be associated with heart block. Arrhythmia syndrome, such as long QT syndrome, may be associated with bradycardia, myocarditis. Patients who have lupus or Sjogren's, who have moms who have lupus or Sjogren's with positive anti-SSA or anti-SSB antibodies, there are risks for heart block in the fetus. And so these pregnancies are usually screened for the baby's heart rate, and they often undergo fetal echocardiogram as well in order to assess the mechanical PR interval for evidence of prolongation and early heart block, understanding that there is very little that we can do that has been proven to be beneficial, but nonetheless, there are therapies that are available should that be the case in the patient. And infiltrative disease such as tuberous sclerosis can also be associated with heart block. So I would say you're called to see this infant who is having a heart rate of 75 beats per minute. You perform an EKG. Any infant suspected to have a rhythm abnormality, you must perform an EKG. That's what's going to give us the diagnosis. So we'll see, as in the previous section, we saw a lot of echo for anatomical heart disease. Now in this section, we'll see a lot of EKGs for the rhythm issues, all right? So here, if we look, we can see that the P rate, we see nicely the P waves here in lead V1 is faster than your QRS rate. And really, there is no relationship between the P waves and the QRS complexes. Okay, so this patient has complete heart block with a very narrow escape rhythm at 75 beats per minute, so maybe a junctional escape, okay? In terms of the management, some babies do just fine with a heart rate of 75 without any issue. So it's gonna be, is this patient symptomatic or not? Of course, the more bradycardic the infant is, or if there's associated structural heart disease, then there's a lower threshold for treating in order to maintain cardiac output, okay? So you may, for stabilization initially, you may give a beta agonist such as isoprostol, epinephrine. The patient may require pacing, which can be done temporarily via the transesophageal or transcutaneous route, but essentially we'll need an epicardial pacemaker, all right? For those who have an escape rhythm of less than 55, regardless of the clinical status of the infant, even though most below 55 tend to be a little bit borderline where their hemodynamic status is, we'll go ahead and put a pacemaker. And if they have significant congenital heart disease, the threshold is with a higher heart rate at around 70 beats per minute, okay? Or if there's ventricular dysfunction. Now, in terms of the tachyarrhythmias, we can divide them into supraventricular or ventricular in type, okay? So the supraventricular arrhythmias, they may originate from the atrium, so any tissue that's above the ventricle, the atrium or the AV junction, okay? The atrium, such as ectopic atrial tachycardia, atrial flutter, from the AV junction, such as junctional ectopic tachycardia. We can also classify them in terms of the mechanism of the arrhythmia. Is this an automatic tachycardia that has an ectopic focus that continues to fire, or is this a reentrant tachycardia that involves a circuit? Okay, the automatic types being an ectopic atrial tachycardia, junctional ectopic tachycardia, and then the reentrant types being atrial flutter, which is an intra-atrial circuit that is set up, or AV reentrant, AV node, or reentrant tachycardia, where the circuit involves the AV node. Okay, so let's talk about the atrial arrhythmias quickly. So atrial flutter is thought to be a reentrant circuit within the atrial myocardium itself. It's very regular, a rapid atrial tachycardia with visible sawtooth flutter waves. AV block is usually present with RR intervals and multiple of the PP intervals, all right? And the atrial rate is usually up to 300 to 500 beats per minute. So here we have a very nice ECG. I think if you ever saw a baby in flutter, you'd want to have this ECG because with your eyes closed, you can see that this is a flutter ECG, right? So nice sawtooth waves here. And we have about 4-to-1 conduction here between the P rate and the QRS, with a QRS rate of about 100 to 150, depending on the conduction. right? Again, the management is going to be dependent on how stable or unstable the patient is, but usually responds well to synchronized cardioversion, okay, at 0.5 to 1 joules per kilo. In the EP lab, we could also do pace termination. And in terms of medical therapy, your class 1A and 1C and 3 antiarrhythmics are the medications of choice. So medications such as flecainide, amiodarone, but they're rarely needed. Most babies respond well to that initial cardioversion, and if they revert to another cardioversion, we rarely have babies where we need to use long-term antiarrhythmic therapy, but it could be needed, okay? In terms of maintaining sinus rhythm, we may use propranolol or digoxin for maintenance therapy, and usually has a good prognosis, rarely recurring, and rarely requires long-term treatment. So in our practice, we probably kept the baby, if they needed medication in the neonatal period, perhaps for the first 6 months to a year, and then wean them thereafter, and most patients do well. Okay, those who have structural heart disease definitely have a higher incidence of recurrence, and those may need to be on longer-term therapy. Ectopic atrial tachycardia is due to an automatic focus within the atrial myocardium. It may be incessant and may also be associated with ventricular dysfunction, and may be confused for sinus tachycardia, except that it's differentiated from sinus tachycardia by the P wave morphology and the ECG, which is why, again, I said that all patients with suspected rhythm abnormality need to have an ECG performed. Okay, so with a 12-lead ECG, we'll be able to tell if this P wave is truly a sinus P wave or if it's from an ectopic focus, okay? The heart rate is typically moderately elevated and may be within a normal range for age, except that the resting heart rate is inappropriately elevated. And in this particular type, it behaves just like your sinus node and is responsive to catecholamine. So there's a characteristic warm-up period with initiation of the tachycardia and cool down. It's not like some of our other tachycardias that we're going to mention in a moment where there's abrupt onset and offset, okay? And if there's associated first or second degree AV block, it may give a clue. All right. So usually, because this is an ectopic focus, it will not terminate with pacing, okay? And it's not usually responsive to DC cardioversion. This tachycardia usually requires medication for control. But we can see in this 12-lead ECG that the P waves are inverted here in AVF and also in 2. So this is not a sinus P. Usually the sinus P's are upright in 1, 2, and AVF. But in this patient, there is an inverted AVF. So this rhythm is ectopic atrial rhythm or ectopic atrial tachycardia, okay? So again, you want to avoid adrenergic stimulation if the patient is febrile. You want to make sure that they're cooled. If they're on inotropic agents, you want to try to wean those if you can. And then for medical therapy, the class 1A, 1C, and 2 medications are preferred, or class 3 agents such as amiodarone. And we may be able to control with one agent or a combination. Okay, amiodarone is quite effective, and careful monitoring is needed during initiation, especially ventricular dysfunction is this in the case of amiodarone, because you can exacerbate or worsen the ventricular function if you give a rapid bolus, okay, which can be catastrophic for the patient. Radiofrequency ablation in incessant cases or surgical resection of the automatic foci, but most of the times you can control medically. Okay, so now to our classic SVT, even as a cardiologist, we think supraventricular just means any arrhythmia above the ventricle, including the atrial and junctional tachycardias. But what most people call SVT are specifically what are known as AV reentrant or AV nodal reentrant tachycardias. Those tachycardias where the circuit involves the AV node. Okay, so usually a narrow complex QRS tachycardia, it may be wide if there's rate-related bumper branch block, or if there's antidromic tachycardia in the setting of an AV reentrant tachycardia. Okay, if P waves are present, they usually follow closely the QRS, so narrow RP tachycardia, okay, short RP, and usually a 1-to-1 AV relationship. They often begin abruptly and also terminate abruptly, okay? And the tachycardia involves an antegrade and a retrograde limb, with the AV node being involved in the circuit as one of those limbs. So this is the classic ECG. You have a neonate, the nurse calls you to say that the heart rate is 250 beats per minute. When you go to assess the patient, you notice that you see this narrow QRS rhythm. You do a 12-lead ECG, no discernible P waves on first look, and just this narrow complex rhythm with a regular RR interval. So there's a fixed cycle length here, and you suspect, yes, this is SVT. So it's either AV reentrant or AV nodal reentrant. AV reentrant tends to be more common in the neonate, as they tend to have persistence of these muscle fibers in the AV junction that allow for that extra limb of the circuit. we'll talk a little bit about pre-excitation and WPW, but many patients without manifest, WPW on the ECG may have what we call a concealed accessory pathway, where that bypass tract conducts retrograde, but doesn't conduct antegrade. But because of its presence, it puts the patient at risk for SVT episodes. So if you see this, you want to know, is the patient stable or unstable? Okay, and we'll go through those the approach in a moment in more detail. But is this patient stable or unstable? If this patient is unstable, they require synchronized cardioversion, again 0.5 to 1 joules per kilo. If the patient is stable, you want to try vagal maneuvers, ice to the baby's face, or prepare to give adenosine, usually 0.1 milligrams per kilogram, no more than 6 milligrams for that first dose, usually 0.1 per kilo, and then double it to 0.2 per kilo if the first injection did not work. Now, adenosine needs to be given at an IV that is closest to the heart, via followed by a bolus of saline, a very quick bolus, in order to ensure that the adenosine gets to the heart before it's deactivated by tissue deaminases. Okay, so just a little bit about WPW. It's the prototype for AV reentrant tachycardias. Okay, and this is where you see the manifest pre-excitation on the ECG. That short PR interval that ends in the slur up to the QRS, so-called delta wave, okay, is pathognomonic for WPW. Okay, but as again, not many patients have WPW, though you may see it once the tachycardia terminates, and then you would have made the diagnosis. But there are many patients who have a normal baseline ECG without this delta wave, but may have a concealed accessory pathway. It doesn't conduct antegrade, and that's the reason why you don't see it on the ECG, but it may conduct retrograde and allow for the setup of supraventricular tachycardia. Okay, so again, unstable synchronized cardioversion, stable vagal maneuvers, or adenosine. All right, and if there are repeated episodes and it's difficult to control, you want to consider antiarrhythmics such as esmolol, amiodarone, procainamide. Okay. In terms of prevention of recurrences, the decision is multifactorial. Was this an episode that was difficult to treat because there was repeated reinitiation of the tachycardia? Is there structural heart disease that is going to make this patient at risk for having recurrent episodes? But in terms of prevention, we tend to prefer beta blockers. Okay, you want to avoid digoxin if WPW is suspected, because you'll slow conduction through the AV node and potentiate antegrade conduction down the bypass tract. And if the patient has an atrial arrhythmia, they could have a ventricular arrhythmia and a sudden death episode. So we avoid digoxin in all patients who have WPW. Okay. You may need to use your class 1C agents for difficult to treat cases. Amiodarone, again, sotalol in difficult cases, mostly where you cannot do an EP study to ablate, which is in the smaller infants. But even over time, we've been doing smaller and smaller patients in the EP lab, for ablation of these accessory pathways. But the treatment of choice ultimately in the patient who can tolerate it is EP study and ablation. Okay, junctional ectopic tachycardia is an automatic tachycardia where there's increased automaticity within the His bundle. It's a narrow QRS tachycardia because it originates at the His junction. Okay, and usually the heart rates are between 180 and 240 per minute. In this tachycardia, there's AV dissociation with a slower atrial rate. So we saw with heart block that the patient is bradycardic, the atrial rate is higher and the ventricular rate is slower. But with junctional ectopic tachycardia and also with ventricular tachycardia, the ventricular rate is higher and the atrial rate slower. Okay. With junctional ectopic tachycardia, the atrial beats may conduct periodically, result in periodic shortening of the RR interval. And it may resemble VTAC if you have at baseline a wide QRS. It's observed mostly in two clinical settings, most commonly in the post-op period in infants and children following cardiopulmonary bypass for congenital heart disease, the type of heart disease most commonly associated with tetralogy of Fallot. But in the neonatal period, you can have patients with congenital junctional ectopic tachycardia, even though this is a rare finding. Okay. Now, for congenital junctional ectopic tachycardia, the heart rates are usually between 160 and 300, and it may present with varying degrees of congestive heart failure. The cause is poorly characterized, but is associated with late onset AV block. It's thought that the junction just continues and then burns out. So histologic degeneration of the His bundle has been demonstrated in patients who die suddenly, and the mortality is high. Up to 34% has been reported. Okay. There's actually a patient that we had, a newborn who was born to a mom by emergency cesarean section because of fetal tachycardia. And postnatally, when we did the ECG, we saw this tachycardia. You'll notice here the orange arrows are the P waves. So here, 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 and here, you'll see the P rate, which is approximately 120 beats per minute, okay? And then here you see the ventricular rate. These purple arrows represent where the QRS complexes are, right? So the ventricular rate is much faster, you know, approaching 180 to 200, even more than 200 here. This RR interval is very short, you know, perhaps in the 280 range. So you see here that the ventricular rate is a narrow QRS tachycardia, narrow QRS complexes throughout, and the ventricular rate is higher than the atrial rate. Okay, so narrow complex tachycardia with no relationship between the P waves and QRSs, with the QRS rate, the ventricular rate being higher than the atrial rate, again, narrow complex tachycardia is in keeping with junctional ectopic tachycardia. Okay, treatment is indicated if the patient is symptomatic, if there is a rapid, if it's a very fast tachycardia, or if there is decreased ventricular function. And amiodarone appears to be the single most effective treatment, okay, shown to reduce the ventricular rates to less than 150 in 50 to 70% of cases. Multiple agents may be needed in difficult cases, so a combination of amiodarone with a class 1C agent, and the treatment may be complicated, especially if you're using multiple antiarrhythmics because of the pro-arrhythmic effect of our antiarrhythmic agents, okay? Also, amiodarone may have a negative inotropic effect, which may complicate the management in a patient who already has decreased ventricular function. Okay, and where cases are refractory, you may have to go in and ablate the His conduction system and, you know, electively place a pacemaker in order to maintain appropriate AV synchrony and heart rates in the patient, and ultimately, you know, prevent sudden death in the future related to burnout of the AV node in this particular group of patients. The patient that we had developed ventricular dysfunction, arrested, and needed ECMO in order to maintain, you know, systemic perfusion. And we underwent a surgical ablation of the AV node. And she had to have 2 procedures in that regard. And then placed a pacemaker, and she's doing well now with her pacemaker with good ventricular function. Ventricular tachycardia, thankfully, is very rare in the neonate, okay, but we know it's a regular wide complex tachycardia, maybe monomorphic or polymorphic, okay? And just one thing to note, the neonate has a very narrow QRS. So, you know, having a baseline ECG is helpful, especially you'll know what the patient's ECG is like in sinus rhythm, because with ventricular tachycardia in the neonate, the QRS may be just only slightly more wide compared to the baseline ECG. Like in this patient, you would think, oh, it is not too wide, but for this baby, it actually is wide. This is a patient who has a ventricular tachycardia. You can see here the retrograde conduction to the atrium. So you have this very short RP interval here, okay? You have to consider if the patient has it, does the patient have a cardiac tumor? We did have a patient who had multiple rhabdomyomas who presented with ventricular tachycardia related to the rhabdomyomas. Is this a patient with cardiomyopathy? Do they have myocarditis? Are there electrolyte derangements? Does this patient have a channelopathy? Is this a manifestation of long QT syndrome or catecholaminergic polymorphic ventricular tachycardia? Okay, and in the management, you know, we go back to our protocol. Is this with pulse or pulseless? You know, of course, pulseless VTAC is CPR and defibrillation, but with a pulse, you know, you want to do synchronized cardioversion, 0.5 to 1 joules per kilo, and then medication-wise, lidocaine, amiodarone, procainamide. And if it's incessant, especially with ventricular dysfunction, the patient may require ECMO for stabilization. You know, and we had one patient who had incessant VT, was cardioverted multiple times, but kept going back into VT, had to be stabilized on ECMO, and ultimately required a heart transplant. Okay. Long QT syndrome associated with the genetic abnormalities, as you see outlined here. There may or may not be a family history, and may present with sinus bradycardia even in the fetus, you know, with 2-to-1 AV conduction. Because of the prolonged repolarization of that ventricle, all the P waves may not conduct and may manifest like a heart block kind of picture. Okay, is associated with torsades and sudden death, and the treatment includes prevention of torsades episodes with beta blockers. The prototype we use is nadolol. We can also use propranolol. Okay, and in the future, the patient will require defibrillator if there is syncope, history of VT, or family history of sudden cardiac death. And this is just a patient who we had here, where you see the prolonged QT interval, and then the patient went into our torsades. So I would say that was a quick run, and definitely not exhaustive, but I hope it was at least a good, you know, whet for your appetite, so that you would continue to approach the management of our neonates with heart disease, both critical congenital heart disease and arrhythmia, perhaps with less fear, but with a more methodical approach, being willing to work through and to establish the diagnosis. And, you know, with the support from our cardiology colleagues in making that diagnosis and improving the outcomes for these patients. Okay. I would not be where I am today without the support of the team. And I don't have any pictures of my Jamaican colleagues here, but, you know, for those of you who are part of this conference, you know, Dr. Scott, Dr. Forrester, Dr. Tomlinson, you know, you all have been an encouragement to me. You know, Dr. Scott, having the opportunity to work with you as SHO, you know, in those early days, I didn't think that I would be here, but, you know, thank you for allowing me that opportunity. And I see how those steps played a role in allowing me to be where I am today. And I'm grateful for the desire to collaborate and to maintain the relationship with the team back home, because I think that there's so much more that we can learn from each other, and also do with each other, so that we can improve the care offered to our patients, you know. And when I say our, I mean or globally, you know. And thanks to the UHealth Host Children's Congenital Heart Center, these are the pictures of my colleagues here, including our support staff, our fellows and faculty. And yeah, and thank you to all my mentors and colleagues, and thank you to the general pediatricians in this conference as well, those that organized this conference, because you all also hold a special place in my heart from the time that we had spent together during my training and working at university. So thank you again. And yep, looking forward to more excellent talks in this conference. Thank you.
Well said, Dr. Hunter. A mammoth task to complete in a relatively short period of time, but you did well. Excellent presentation. Thanks for all the visuals. And, you know, we don't have to be cardiologists or even pediatricians to have gained a lot of knowledge from your presentation. Thank you so much. I'm going to remind the participants that Dr. Hunter will be answering questions in the Q&A section, so please post your questions there. And moving right along, receiving the baton and taking off out of the blocks from Dr. Hunter, we have Dr. Charmaine Hope Scott. Dr. Scott is one of the Caribbean's leading pediatric cardiologists. She is a former associate lecturer of the University of the West Indies in the Department of Child and Adolescent Medicine, and former consultant pediatric cardiologist at the Bustamante Hospital for Children in Kingston, position she held for over 20 years. She's a graduate of Westwood High School. Dr. Scott received her training in medicine at the University of the West Indies, Mona, Kingston, Jamaica, and pediatric cardiology in the United Kingdom at the Institute of Child Health London, Great Ormond Street Hospital. In January 2006, she established the Children's Heart and Paediatric Center, a private facility in Jamaica that provides comprehensive care for children with heart disease. Dr. Scott is a founding board member and former director of Chain of Hope Jamaica, a UK-supported charity that facilitates treatment for children with heart disease in Jamaica. She was its first chairperson. To facilitate the comprehensive care of children with Down syndrome, many of whom have congenital heart disease, she established the Jamaica Down Syndrome Foundation, a charity organization which provides support for children with Down syndrome and their families. In December 2017, she interviewed and was selected by Down Syndrome International as the chair for the Guideline Development Group of Cardiac Disorders. The group has recently authored a paper, Consensus Statement on Cardiovascular Complications of Down Syndrome, Scoping Review and Expert Consensus, which has been accepted for publication by the journal Circulation. An avid track and field fan and former competitive sprinter, she was the champion female athlete at the UA Intercampus Games held in Barbados in 1974, and team doctor for the Jamaican team to the 12th IAAF World Championship in Bidgoa, July 2008. Dr. Scott has published peer-reviewed articles and presented papers at many local and overseas conferences. She is the recipient of numerous awards, starting with the Princess Alice Award bestowed on her by her alma mater to pursue her first degree, which was in natural science at UA. She was also selected as a phenomenal woman in the 2008 Jamaican Gleaner Phenomenal Woman feature. In June 2012, she was one of the inductees at the Westwood Old Girls Association's inaugural Hall of Fame. And in August 2013 was conferred with a Jamaican National Award, the Order of Distinction in the Rank of Officer, OD. She received the Paul Harris Fellow and Vocational Service Award from the Rotary Foundation of Rotary International in October 2013. She's the Paediatric Association of Jamaica honoree for the year 2015. And in February 2019, she received an award from the Ministry of Health Family Unit for exceptional commitment and support to cardiac cardiology in Jamaica. In July 2021, she was one of the Caribbean Cardiac Society's honorees in recognition of her contribution to pediatric cardiology in the region. Highly motivated and strongly passionate to serve others, she lives by her high school's motto, Ora et Labore, by prayer and by work. And this just raises the surface when it comes to Dr. Scott and her contribution to pediatric cardiology in the region. So without much further ado, I hand you over to Dr. Charmaine Scott, who will enrich our minds with the topic updates on rheumatic fever. Over to you, Dr. Scott.
Good morning, everyone. Thank you for inviting me to present at the symposium this morning. My job is to review rheumatic fever in 20 minutes. So I'll go straight into it. What is rheumatic fever? Well, my talk outline is as on screen. I'll go through a bit of what is rheumatic fever, then the pathogenesis and epidemiology, followed by the clinical presentation and diagnosis, then management and treatment, and a little on global and local trends, and then the way forward. So what is rheumatic fever? Rheumatic fever is the most common cause of acquired heart disease in children in lower and middle income countries. Acute rheumatic fever is a systemic post-infectious non-suppurative sequelae of pharyngeal infection with group A beta hemolytic streptococcus gas. It may also be seen in some countries post-skin infection. Only about 0.3 to 3% of children with a strep throat go on to get rheumatic fever, suggesting that there may be a genetic predisposition to this condition. Recent studies have reported HLA class II encoded on genes of chromosome 6. The importance of rheumatic fever lies in the capacity to cause severe and permanent heart damage. In order to understand the pathogenesis of rheumatic fever, I'll spend a few minutes just reviewing the streptococcal organism. We see here that the protoplasm is surrounded by a cell wall. The cell wall includes peptidoglycan, polysaccharide, and protein, which determines grouping and typing. Coming from the cell wall or cell membrane, is a fimbrial antigen M protein, and this is important in virulence of the organism. Then there's a capsule which surrounds the cell wall, made of hyaluronic acid, and the organism excretes extracellular substances which are very important in enhancing virulence of the organism. In the lab, overnight incubation on blood agar medium shows that the organism lyses blood cells, leaving a clear zone of hemolysis around the colonies, which appear in chains or in pairs, hence beta hemolytic streptococcus. The pathogenesis involves a reaction, antibody response to the antigen, in particular M protein in the wall of the cells, to GABA. This antibody causes autoimmune damage to heart valves, subcutaneous tissue, tendons, joints, and basal ganglia in the brain. Histologically, nodules formed in reaction to the inflammation may be seen as swelling and causes fragmentation of collagen fibers. It's thought that the antibody response to the tissues is mainly because the M protein shares or cross-reacts with some of the components of tissue like heart valves. There is a close interaction between agent, host factors, and environmental factors when we look at the epidemiology of the disease. So the appropriate highly rheumatogenic agent in a very receptive host, such as children 5 to 15 years with an inherited susceptibility, and the right environmental factors such as poor sanitation and overcrowding causes an intimate reaction between these factors is important in the evolution of the disease. The disease is really thought to be sort of malignant, and the reason is the setup for recurrent infections. Now, looking at the slide, you will notice that by the time the patient has the first infection of first presentation of acute rheumatic fever, it's thought that they would have several strep throat infections, as it were, priming the body for the immune response. Then, after the first episode of acute rheumatic fever, there is increased susceptibility to further attacks, so introducing heart damage or making heart damage worse. The diagnosis of rheumatic fever is still a clinical diagnosis. There is no one single test that can be done to make the diagnosis. We go back to the Jones criteria, which we are all familiar with, which Dr. Jones, an American cardiologist, back in 1994, first made a recommendation for the diagnosis of rheumatic fever. There have been many revisions, the most recent of which is 2015, and I will briefly go through those. So, what's Jones' criteria? Well, Dr. Jones suggested that there are certain highly related or associated features with the condition, and these are polyarthritis, carditis, chorea, subcutaneous nodules, and erythema marginatum, the so-called major criteria. Then he listed a number of minor criteria, which included fever, polyarthralgia, elevated ESR, acute phase reactance elevation, prolongation of the PR interval 1 ECG, and a past history of rheumatic fever or rheumatic heart disease. So that was basically the first criteria that, as stated. In 1956, it was modified to include evidence of recent streptococcal infection as a minor criteria. Then in 1965, it became mandatory to have evidence of strep infection as part of the diagnosis. However, with an exception being chorea. So if the patient presents with chorea, there was no longer the need to have evidence of strep infection. In 1992, another exception was included, exception to presence of strep infection, and that was indolent or rumbling carditis. And in 2003, the exception again of past history of rheumatic fever or rheumatic heart disease made it not necessary to have evidence of strep infection. Every revision basically increased the specificity but decreased the sensitivity. Please note that a positive ASTRO alone does not equate to rheumatic fever. The 2015 update, which is the most recent update, basically made the diagnosis of rheumatic fever, the Jones criteria, easier and more sensitive in high-risk populations to include certain features that are not common in not so high-risk populations, such as joint involvement. For joint involvement, monoarthritis can be accepted, or monoarthralgia as a major criteria, and lower acute phase reactance, that is an ESR of 30 or less, and a CRP, a lower CRP, may also be accepted as minor criteria. So I will now review the clinical manifestations of acute rheumatic fever. The most serious manifestation of rheumatic fever may be life-threatening heart damage. This occurs in about 60 to 70% of first attacks of rheumatic fever. And recently, with screening of all cases of rheumatic fever, that has increased to 91%. All the structures of the heart may be involved. That is a pancarditis. The most common presentation, however, is a valvulitis affecting the left heart valves, mitral alone or mitral and aortic. Aortic alone is almost never seen, and rarely tricuspid valve may be affected. The younger the age of the first attack, the more likely there is to be carditis and the more severe the carditis. Myocarditis is rare, so systolic function is usually preserved. The clinical presentation of cardiac involvement includes clinically, murmur may be present or murmurs, a pericardial friction rub, cardiomegaly, tachycardia, and rhythm abnormalities. The X-ray will show in moderate to severe cases cardiomegaly, and this shows an 8-year-old girl who had acute rheumatic fever with cardiac failure. You see there's cardiomegaly and plethora, and 4 weeks after hospitalization, we note that there is a decrease in cardiomegaly. So chest X-ray may be helpful, as well as ECG, and we're looking for the prolonged PR interval, which is not so common nowadays. More commonly, we see left ventricular hypertrophy, left atrial enlargement, and sometimes right ventricular hypertrophy. The echocardiogram, of course, is useful, and it allows visualization of the heart valves, direct visualization of the heart valves. We may see regurgitant jets. We are able to assess myocardial function, and as well as a pericardial effusion if present. The joint manifestations include, usually it is the joint involvement that heralds the acute condition, and arthritis is usually present in 75% of first attacks. It's migratory, multiple, medium-sized to large joints are involved, and it resolves within a week with or without treatment. Joint involvement may also be just arthralgia. Chorea, not as often seen as in the earlier days, is a neurological manifestation when there is involvement of the basal ganglia of the brain. There may be some emotional lability. It's more commonly seen in females. It may follow or other manifestations or precede them. And 50% of persons who have chorea over time may in fact develop rheumatic heart disease. Erythema marginatum, again, not commonly seen, is a diagnostic feature of rheumatic fever. There is a circular annular map-like rash with central areas of pallor and it's chiefly seen on the trunk, but also on the arms and legs. It's very transient and evanescent. And subcutaneous nodules may appear as painless, pea-sized nodules over the extensor surfaces of the joints, as well as over the spine and on the scapulae. This slide summarizes the timing of the major manifestations. Of note are polyarthritis, carditis, and erythema marginatum arise early and peak around about 4 weeks, which is around the time when chorea and subcutaneous nodules may appear. Now, the management of acute rheumatic fever would involve, of course, investigations, clinical examination, history. The investigations include a complete blood count, urine electrolytes, acute phase reactants, evidence of strep infection, the throat swab or an Astor, blood culture, and of course, chest X-ray, ECG, and echocardiogram. We recommend that all cases of suspected and proven acute rheumatic fever be hospitalized. And the goal of treatment is to eradicate gas, treat all the associated features, bed rest improves, certainly if there's cardiac involvement, that would help. Anti-inflammatory agents include aspirin, brufen, and steroids. Now, the choice with respect to anti-inflammatory agents remain aspirin. However, ibuprofen is now being introduced in some centers because it has fewer dosing requirements per day, less side effects, for example, gastric ulcers. And so it is now being used in some centers as first-line anti-inflammatory agent. Steroids is used if there's presence of moderate to severe carditis. Of course, if there's congestive cardiac failure, the appropriate management for that is done. The entire course of treatment usually takes around 6 to 8 weeks. It is important that long-term follow-up be done because, as mentioned, this can become malignant, and we'll discuss further on secondary prophylaxis later in the presentation. Rheumatic fever is a class 1 notifiable disease, so on suspicion, it has to be reported to the parish health department within 24 hours. Treatment of the eradication of streptococcal organism involves the use of penicillin, and it is advisable that we give a single dose of injection with benzathine penicillin or Panadior in the doses indicated there. Or we may give oral penicillin. If that's the choice, then the penicillin has to be given for 10 days to completely eradicate the streptococcal organism. Where there's allergy, then one can use erythromycin, but with whatever the choice of oral route, it has to be given for 10 days. Secondary prophylaxis is always indicated to prevent further attacks of acute rheumatic fever, and hence the opportunity for further heart valve damage or introduction of cardiac involvement. We recommend, while in hospital, that the patient receives the Panadior every 2 weeks, as they are at risk in that setting for exposure to gas. On discharge, it's given every 28 days at the local health center. In some jurisdiction where there's a high incidence of rheumatic fever, one may consider giving the Panadior every 21 days instead of every 28 days. Or if a patient is completely compliant with Panadol 28-day regime and they still have breakthroughs, that we probably consider giving it every 21 days. So here, this slide shows the dosing and route for the secondary prophylaxis. We see that we can use sulfonamides where there is an allergy or for whatever reason we cannot give Panadol, it's not available or whatever. You can in fact use sulfonamide. That is preferred over erythromycin for secondary prophylaxis because it's just a once a day preparation. Now, how long should we treat with secondary prophylaxis? If there is carditis and residual rheumatic heart disease on clinical or echo grounds, then duration of secondary prophylaxis is lifelong. If the carditis does not lead to residual heart disease, then we can consider a shorter period of prophylaxis. That's 10 years or until 25 years, whichever is longer. If there is rheumatic fever and the patient received heart surgery where they have artificial valves, they will still require lifelong Panadol penicillin. Rheumatic fever without carditis, prophylaxis is given for 5 years or until age 18, whichever is longer. Patients with rheumatic heart disease will require infective endocarditis prophylaxis for dental or surgical procedures. If the patient is using penicillin for their secondary prophylaxis, then we should consider, and in fact, we should introduce another drug. And the drugs that have been suggested are clindamycin, azithromycin, and clarithromycin. And this slide shows the dosing regimes that may be used in infective endocarditis prophylaxis. I will now spend a few minutes reviewing international and local trends in the occurrence of this disease. Reliable data is difficult because, especially in the lower income and poorer countries, it is very difficult to get reliable data. The incidence in developed countries, as we know, has decreased significantly over the years, such that it is well below 1% per 100 population in most developed countries. In lower and middle income countries, it is in a region of up to 150 in some countries per 100,000 population. In 1994, WHO registered 12 million cases of acute rheumatic fever and rheumatic heart disease worldwide. In 2011, 15 million. Now it is estimated to be around 40.5 million because of pickup of cases being screened by echo in the field, particularly in schools. Now, if we look at local trends, we have had 2 surveys. Our program started in 1985 by Dr. Doreen Millard, and she did 2 surveys. The first in 1975 to 85, and the second in 1989 to 1995. So if of note, the number of cases in survey A was 158, and that decreased to 282 in the subsequent study. Of note, the percentage of patients presenting with carditis increased in the latest study, suggesting that there was poor compliance with secondary prophylaxis. At the Bustamante Hospital for Children, data collected shows that the number of admissions per year has decreased over time from around 30 per year to around 7 per year. In 1964 to 67, we were seeing around 30 cases compared to a recent survey showing around 7 cases being admitted per year. And this just compares the national experience with the Bustamante experience. The Bustamante experience is in orange, the national experience in blue, and you will see that there has been a decrease incidence based on those studies of rheumatic fever. Now, I'll just quickly review the history overall. As we know, the condition first came to light in the 30s, the golden age of bacteriology, when gas was discovered. Dr. Jones established his criteria and established that penicillin and aspirin be used in the treatment. The 60s to the 70s was a decade of dissemination. There was a lot of advocacy and education. And around that time, the American Heart Association was formed to fight what was then called childhood's greatest enemy, rheumatic fever. The 70s to 2000, it was indeed a neglected disease. And then there has been a resurgence of interest and research since 2000 to the present time. The highlights have been better screening because of availability of echo services, portable ones in particular out in the field. And in 2018, the World Health Assembly made a resolution to end rheumatic fever and rheumatic heart disease. So there's been renewed interest in early intervention and secondary prophylaxis. What of the way forward? The only way to reduce the scourge of this disease is the development of an efficient vaccine to eliminate rheumatic fever on the global stage. This will require further investigation and investment, that is money, into finding ways to develop this vaccine. We would need to elucidate the immunopathogenesis of the host response to gas, as well as to research the genetic predisposition of the host to rheumatic heart disease in order to attain this goal. My references include this list, and in particular, up to date, that should have been up to date, was very useful, I find. And if you have time, you may go to that reference. It was put online in June 2022. Thank you for your kind attention, and I'll be happy to invite questions, comments, in the question and answer session. Thank you very much.
Thank you so much, Dr. Scott. That was a very refreshing, history in the evolution of rheumatic fever and rheumatic heart disease from, back in the 30s to the present. I am going to invite persons to put your questions in the Q&A section, please, in the interest of time. But we will entertain 1 or 2 questions live. I'm hoping Dr. Hunter is still here with us. I have a question here, and it says, given the findings in case 2, is there a protocol for appropriate cardiac screening for babies born outside of hospitals? For midwives and other medical personnel doing home deliveries, what would you suggest as simple assessment at delivery?
So as far as I'm aware, there is no current protocol. That's still a population, albeit a small population of the total number of deliveries, but perhaps an increasing one as more people are doing home deliveries or babies are born in birthing centers. But those babies are required to see the general pediatrician, and I guess there may be more control in the general pediatrician's office in doing the pulse oximetry screen within the first week of life. Pertaining to evaluating the neonate there on spot, a lot of changes occur in the transitional period that may cause the baby to have transient desaturation. So desaturation then may not always equate to a child who has congenital heart disease, but I would say the more sensitive screen would be a screen performed within the first 48 hours of life. We want to pick up early so that the baby should see the pediatrician within that time frame, or if they're going to be follow-up with the midwives during that time, a pulse oximetry screen performed by them during that time frame may be beneficial.
Okay, thank you, Dr. Hunter. And one question here for Dr. Scott. This is from Dr. Tracy Gilbert concerning the monoarthralgia and monoarthritis criteria in high-risk patients. Is this a diagnosis of exclusion after other causes of monoarthralgia, monoarthritis is ruled out? Also, please clarify the definition of high and low risk populations.
Okay, well, certainly we would try to rule out other obvious causes for monoarthritis and arthralgia, but it certainly widens the opportunity to entertain the diagnosis when there are other obvious factors in keeping with rheumatic fever, which we don't want to miss and expose the child to chronic heart disease. So yes, we definitely need to rule out other important causes of monoarthritis. So that's, I hope that answers that question. And the second was? Sorry.
The second was, oops, I missed that. Let me find that back. Second question was, also please clarify the definition of high and low risk populations.
Well, high-risk population would be where rheumatic fever, rheumatic heart disease is still common, as opposed to low risk being where it is not a problem anymore, or well below 1 in 100, 1,000 cases. So we are kind of in between.
Okay, all right. I think I have one other question. Let me see.
Sorry, also I just want to add that there are some countries in the Caribbean that no longer see rheumatic fever. I do believe anecdotally in Trinidad and Barbados, it's not an issue, anecdotally.
Okay, we're going to encourage the questions to be put in the chat so Dr. Scott and Dr. Hunter can address those. I was looking for one other question, but because time is up against us, I will allow that question to be answered in the chat. So we will go right ahead to our a short video presentation from our sponsor, Nestle. Thank you, Dr. Scott. Thank you, Dr. Hunter.
You're welcome.
Thank you, Carly.
At Nestle, we support the World Health Organization's recommendation for exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. As babies grow at different paces, health professionals should advise the mother on the appropriate time when her baby should start receiving complementary foods. There are many aspects of the growing infant that we could explore. There are many facets of the development we nurture with Nestle's Nan OptiPro. But today, I would like to capture your attention for the next 5 minutes, focusing on 3 key areas we do believe every infant who is unable to breastfeed should benefit from when using a breast milk substitute. Our Nan infant formula features a staged approach with our exclusive combination of OptiPro, probiotics, and the 2FL HMO.
At Nestle, breast milk has always been the reference standard for infant nutrition. With its high quality and optimum quantity of proteins, it is ideal for long-term health of infants. Research shows that an excess intake of insulinogenic amino acids such as threonine, valine, isoleucine, and leucine increases adipogenesis and leads to accelerated weight gain in the early infancy, defined as a risk factor for higher obesity rate later on. It is then vital that an infant formula tries to mimic as much as possible the quantity and quality of protein in breast milk. The quality of proteins in cow's milk, the base ingredient for infant formulas, is radically different from that of breast milk. That is why at Nestle, we invented
How can I respond?
protein technology that transformed low-quality cow's milk protein into a high-quality whey protein for NAN or TIPRO. The process begins with selected cow's milk fulfilling a high-quality standards being collected and delivered to the state-of-the-art facility. The milk is then sent through a coagulator where it is treated with an enzyme which breaks down the casein micelles, releasing into the whey a specific protein fraction called cGMP, which is rich in insulinogenic amino acids. The whey then goes through a cation exchange column where the cations such as sodium, potassium, calcium, and magnesium are removed. This half-demineralized whey is then sent to the modified whey reactor where anions such as chlorides, phosphates, citrates, and selectively the cGMP are removed, resulting in a demineralized whey protein completely free of cGMP. The selective removal of cGMP results in a unique whey protein with a low content of critical insulinogenic amino acids, which is the key to the amino acid profile of NAN or TIPRO closer to that of breast milk.
As you would have seen, our proprietary casein glycomacropeptide removal process raises the desired milk fractions, coupled with protein quantity reduction, selectively allows only non-OptiPro to deliver far-reaching benefits to little consumers during infancy and far into childhood. It reduces their prevalence of obesity and insulin exposure whenever they are unable to access nature's best. An additional study by Escribiano et al. Using ultrasonography revealed that 6 months, infants receiving the high-protein formula had significantly higher kidney volume and ratios of kidney volume to body length and kidney volume to body surface area than did infants receiving the low-protein formula. It was identified that breastfed infants did not differ from those receiving the low-protein formula in any of these parameters. In this European multi-center clinical trial, we found that higher protein content infant formula increases kidney size at 6 months of life, whereas a lower protein infant formula achieves kidney sizes indistinguishable from that of a healthy breastfed infant, showing the lower stress and workload required by these infants. Choose non-OptiPro for your routine infant feeding needs whenever a breast milk substitute is indicated, and rest assured your little clients are getting our exclusive combination of OptiPro, probiotics, and the 2FL HMO, DHA and ARA in a 1-to-1 ratio similar to that found in breast milk, fueling nutritious growth and immune-boosting experience when compared to other options. Here are a few of the references used throughout this presentation. For any questions or queries, please reach out to your local Nestle representatives. Thank you, and do have a productive conference.
And thank you to Nestle and all of our sponsors so far. I would ask our presenters, the function at the bottom of your Zoom page that says Q&A, when you click on it, you will see the questions there. Simply click on type answer, and then you'll be able to reply, and then everyone will see your reply that way. All right, so thank you again. Back to you, Dr. Antoine.
Thank you, and thanks again to our sponsors at Nestle. So moving right along, taking on our third leg is Dr. Deron Reed, and he is coming to us with a very topical and timely presentation. As Dr. Forrester alluded to earlier, we are hearing a lot of athletes locally and internationally
collapsing on the field. And this brings into sharp focus the need for cardiac evaluation in our young persons and adolescents. So Dr. Darren Reed is a consultant cardiologist at the Cornwall Regional Hospital in the Western Regional Health Authority. He completed his MBBS in 2006 and Doctor of Medicine, Internal Medicine in 2014 with the University of the West Indies. He went on to do fellowship training at the University of Toronto, Canada, in general cardiology and further subspecialty cardiology training in adult congenital heart disease and obstetric cardiology between 2017 and 2020. He also completed a cardiac MRI fellowship at the Royal Brompton Hospital in the UK. In addition to all his cardiology training, he has training and special interest in healthcare quality improvement and patient safety. Welcome, Dr. Darren Reed, and over to you.
Thank you so much for that very kind introduction. And I would like to thank the organizers for inviting me to make this talk. And it is such a privilege to share this platform with my classmate, Juanita. It's so great seeing you. And definitely my other colleagues from Bustamante. So I said in this slide, I have no disclosures, but I would think that I'm a pediatrician by adoption. And I say that because, you know, of my congenital background. So this talk is going to be a little bit different. And you know, a few take-home messages I want you to get from it is importance of an integrated approach in the management of adolescents with cardiac disease, and a little introduction on the basics in cardiac evaluation. So adolescence is a phase of life between childhood and adulthood. And it's considered by World Health Organization between the ages of 10 to 19. And definitely by the American Academy of Pediatricians, it says between ages 11 to 21. Just to note that in Jamaica, so our children transition at the age of 12 into the adult public facility. And you know, my presentation will take this into consideration. So the question is, what is involved in cardiac evaluation in adolescents? And I want you to pause a little, think about it. And oftentimes we focus on the heart itself, but I want to challenge you to think outside of the box. And these children, when they come to me, they come with myriad of issues. And remember, one is they are psychologically, you know, they have psychological issues on the background that they've had frequent hospitalizations in the past. They've had perhaps recurrent procedures done. They may have one or multiple surgeries done. And their education may also have been affected because they skip multiple days from school, and the social support for them may not be very great. So we have to think, so part of my assessment is outside of the heart, and to think also of the other issues that happen with them. And you know, it's also very important that we consider our evaluation as a system. So we have to take a systematic approach and not just look at the heart alone. So we have to consider the patients and their family or the caregivers. And we also have to look at the institutional policies that we have. And do we have the support staff that is necessary and needed for us to do the work that is well needed? And also, we have to involve the primary care physicians, and we have to look at the scope of our specialists. Do we have enough pediatrician, cardiologist, interventional cardiologist, radiologist, perfusionists, congenital surgeons to serve not only the pediatric population, but also the adult population? Do we have specialized nurses? Do we have psychologists? Do we have clinical geneticists? So think about it this way, and we realize that our management is very broad, and it's not just about you sending the patient to me for evaluation. I have to take all these into account. So cardiac findings in adolescents are usually normal, and most murmurs, I can tell you, are benign. So I guess this can end my presentation and we can all move on. But unfortunately, that's not the case. So we need teamwork. And teamwork is very, very important, because this cannot be done by one person or two persons. It has to be a team approach. And this team approach we have to engage the primary care physicians. The GPs are crucial as a foundation of where we want to get. So they're usually the first point of contact. Why? Because they will present with acute illness and they will go to the GPs. They will go for routine medicals. They will also do school medicals, which I do not want you to underplay, because many times with these school medicals, you can pick up arrhythmias, you can pick up murmurs, and we just had a talk on rheumatic fever, and we still have incidental findings of patients being diagnosed with rheumatic heart disease just because of a murmur that was detected. And I want to mention the role they play in the transitional care process. Over 80% of patients who actually default from specialist care. So when a patient is seen at Bustamante and they are referred to us for continued care, many of them, I tell you, will default. And perhaps even before Bustamante can do a formal referral, they will also default there as well. So but guess what? They will see, over 80% of these patients will be seen by a primary care physician. So we have to teach, and we have to educate, and we have to incorporate and let them be aware that early detection and management is crucial for these patients. We need planned, structured follow-up, and we need patient empowerment. The issue is that many of these patients have neurocognitive issues. They've had post-traumatic stress disorder, perhaps from multiple hospitalizations, multiple IV lines. And of course, cardiopulmonary bypass may not be as benign as how we think it is. Perhaps these patients, and a lot of the literature now is looking at neurocognitive changes that can occur from these young children who do go on cardiopulmonary bypass. We have to have integration and coordination of care, and very important, continuity of care. And all this is important if we want to decrease mortality, decrease hospitalization, and to increase quality of life. So the role of the primary care physician in cardiac evaluation is basic back to school foundation, your history, physical examination, and your investigations, which incorporate ECG, chest X-ray, and echocardiogram. The next thing is, when are they to refer? Where to refer? And who are they to refer? So I want to start a quick and look at the history. And, it cannot be just a quick, look over and they go on their merry way, but you have to focus on key points. Look at what their weight changes have been over the period of time from birth until now. Do they have delayed development? What about a history of cyanosis? Do they present with a history of having squatting and cyanotic spells to suggest tetralogy of Fallot or other cyanotic congenital heart disease? Do they have frequent lower respiratory tract infections? And if that's the case, are we missing a cardiac shunt? Do they have decreased exercise tolerance? It may indicate significant heart defects or ventricular dysfunction. Do they have a heart murmur? And if so, when was that heart murmur first detected and what was done about that murmur? Do we just think it's an innocent murmur, or do we exclude other things? Because you have to not rule it, say that it's an innocent murmur until you have a thorough history of the patient. What about chest pain? Ischemic type chest pain is not very common in the adolescent population. But usually if someone presents to me with exertional chest pain, then I have to start thinking about anomalous aortic origin of the coronary artery, where they can have an intramural and an interarterial course. Palpitations, we've had multiple talks on arrhythmias, and I will try not to duplicate the things that have already been said, but also joint pain, sore throat, rashes, and with this we start thinking about rheumatic fever and also autoimmune conditions. They present with stroke. We have to think about cardioembolic. Do they have infective endocarditis? Do they have an intracardiac shunt? We have to think about syncope in the context of our long QT syndrome, which you have to consider, as well as other type of arrhythmia, which was mentioned earlier, like WPW. And we also look and assess if the patients are syndromic. Do they have Turner's, Downs, Vector L or Vector L? And I could go on with the different syndromes that are associated with cardiac anomalies. What are their medication history? Have they ever taken medications like a diuretic? Or have they ever taken a medication like an ACE inhibitor? And if that's the case, why? Why are you on these medications? And of course, we have to consider family history. The incidence of congenital heart disease in the general population is generally around 1%. However, we know it varies between different anomalies, but as a rule, definitely around 3 to 5% hereditary risk for those who do have a family history. So in the clinic, the common syndromes, and these are the common syndromes that will present to you. And I don't put the weird and wonderful in this presentation because I am trying to just sensitize you on the importance of a thorough history and a thorough physical examination, and to detect the issues and to refer as appropriate, as is possible in the context of things. So Turner's, you have a 35% of cardiac involvement. They can have coarctation of the aorta, bicuspid aortic valve, aortic stenosis, hypertension. They can present with acute chest pain or back pain, and it's an aortic dissection. Down syndrome or trisomy 21, 40 to 50% of these patients will have cardiac involvement. Typically, endocardial cushion defects are what we would call your atrioventricular septal defect, whether it be partial or complete. And you also have your ventricular septal defects. Your Vaterel association, greater than 50% of these patients will have a VSD or other cardiac defects. And of course, I have to mention the hereditary aortopathies, such as Marfan syndrome, but you do have Louis Dietz, your Ehlers-Danlos, which is typically your type 4, which is vascular related. And particularly with Marfan, they do have, they can have aortic involvement with aneurysm, mitral or aortic valve regurgitation can be present. And of course, they can also have a primary cardiomyopathy. So this takes us, so with a thorough history, there are key things I want you to gear in on the physical examination. What's the general appearance of the patient? What's the nutritional status? Is there clubbing of the fingers, clubbing of the toes or not? Examine the precordium. Is it hyperactive? If it's hyperactive, it could suggest that there is a high volume state, such as in a left to right shunt or severe valvular regurgitation. Are thrills present, and the location of the thrill? That can guide you into what's happening. If a thrill is at the upper left sternal border, it could be pulmonary stenosis. An upper right sternal border thrill could be aortic stenosis. A lower left sternal border thrill could be a VSD. A suprasternal notch thrill could be aortic stenosis, occasionally pulmonary stenosis, can be PDA or coarctation. And do we have radiation or involvement with the carotid arteries, which could indicate aortic stenosis or coarctation of the aorta? Pay attention to the peripheral pulses as well. Strong arm pulses and weak leg pulses could suggest coarctation of the aorta. You do not want to miss these things on physical examination. The right brachial artery pulse, is it stronger than the left brachial artery pulse, may also suggest coarctation of the aorta or supravalvular aortic stenosis. Is a pulse bounding? It can be found in aortic runoff lesions, such as PDA and aortic regurgitation. On physical exam, I want you to also focus on the blood pressure. Now, every single adolescent that presents should get blood pressure done. And sometimes we may need to do forelimb blood pressure measurements to rule out coarctation. So if the blood pressure in the upper limb is greater than the lower limb blood pressure, that may indicate coarctation. If the blood pressure in the thigh or calf is typically around 5 to 10 millimeters higher than the blood pressure in the arms, and that we should remember. When we examine these patients, do they have a surgical scar or not? And I mention these details because, unfortunately, many of our patients, as I said, their background history, they may have neurocognitive impairment. Oftentimes, they don't know what procedures were done. They can tell you, oh, I had a hole in my heart. Some of them cannot even tell you that. And the issue is, we also have great difficulty in obtaining medical records. Quite the number of patients, we try to, of course, have a good transitional system from Bustamante, where from time to time they send over all the information. But the issue is that many of these adolescents would have defaulted follow-up before they actually present or represent to us in the adult side of things. So they don't usually have any idea of what's happening. If their parents, usually the mother, sometimes can fill in the gaps, but oftentimes they don't have the educational background or the knowledge to give us the information that is needed. So it's very important that we have to pick up on all the things necessary to try and do the best that we can. So the question is, so when to refer? So I would say, when one or more of the following are present, the murmur is likely to be pathologic and require cardiac consultation. If it's associated with symptoms, cyanosis, if you have an abnormal chest X-ray, so there is cardiomegaly, there's a suggestion of pulmonary vascular abnormality. Get an ECG. Is the ECG abnormal? Is there a systolic murmur that is loud, usually grade 3 out of 6, associated with a thrill and long in duration? Any diastolic murmur you hear must be referred. Abnormal heart sounds, abnormally strong or weak pulses. These are just basic guidelines. So I want to take you, because I want to gear my talk to a bit of local data. And I'm trying to definitely put some information together to see the cases that we have. And this is the cases that since I've been back for the last 1 year that I've come across. Definitely for the Western region, we should include Cornwall Regional, Falmouth, as well as Savannah Lamar. And we group them into whether these cases for the adolescents, they are congenital or acquired. Many of the cases, as expected, would be congenital. And many of them are simple lesions that we are seeing. Unfortunately, many of them are unrepaired. And I will go into that a little bit later. But so far, what I am seeing, you have atrial septal defects, usually the secundum type. You have VSDs. You have patent ductus arteriosus that is unrepaired. And unfortunately, I have around 3 cases of Eisenmenger physiology. And we've seen coupled tetralogy of follow repair, which now presents with problems, because by the time I am seeing these adolescents, I have to deal with the latter complications of their surgery. And if they've had a tetralogy of follow repair, oftentimes they are left with residual pulmonary regurgitation that we should monitor over time. And it's a matter of timing as to when we would put a valve in. So now that becomes my worry on the other side. Of course, the other case that I see is I have 1 case of congenital giant right atrium, doesn't meet the criteria for Epstein anomaly. And she also has associated Turner's. There are a couple partial AVSD, and these are your endocardial cushion defects, so your atrioventricular septal defect. And unfortunately, these are unrepaired. So I do have partial atrioventricular septal defect and complete atrioventricular septal defect unrepaired. And I have 1 single ventricle physiology. That's a double inlet left ventricle, a LTGA with VSD and some pulmonary stenosis. And of course, your hereditary aortopathy, which the common one that I do see would be Marfan. These children can also present with arrhythmias. And it's very important because any history of palpitation, even if the ECG, if they've had surgery done before, even if the ECG doesn't show any overt arrhythmia, I still like to document a Holter, ideally a 48-hour Holter on these patients, because we know that they are at risk if they've post-repair, they are at risk for intra-atrial re-entrant tachycardia, which is, put simply, is more of a scar-related tachycardia that they get, like a scar-related atrial flutter, really, that they get that's related to the surgery that they did. So that's why it's very important that when a referral comes to me, I try to get what the surgical details, because it impacts the management of the patient. What was done at the time of surgery? Was there any complication? Where the sutures were put, and so on. So of course, so with their history of surgery and tachycardia, I want to know if they're having an atrial flutter, which is usually an intra-atrial reentrant tachycardia. Other things like WPW, and of course, arrhythmogenic cardiomyopathy, we have to be on the lookout for as well. I have had 1 case that presented who was playing competitive basketball and collapsed on the court and was noted to be in VT. So what are the acquired cases so far that I am seeing? Rheumatic fever, which is like a carditis, rheumatic heart disease, definitely tops the list. There is the run-of-the-mill pericarditis, which is usually virally, related, or sometimes can be autoimmune, with patients with lupus. And a few cardiomyopathy. The background history on the cardiomyopathy cases would be related to myocarditis and also those who have autoimmune conditions. And hopefully, if I'm invited to do this talk again in the future, I will be able to give you some local statistics and data in terms of our population base, and definitely some outcomes data. So what are the challenges? Because I do have challenges. Congenital heart defects are the most common, birth defects that we will have. And in first world country, many of them are post-repaired. And, coming back now after my studies, then I have to change my thinking and my approach. You have to curtail it to your setting. So a lot of things I cannot apply first world data and first world the ideas to our local setting. Too many of our patients are still unrepaired in Jamaica. A lot of I would say up to 70% of the adolescents who I see with congenital heart disease, they are unrepaired. So the question you should ask yourself is, why is this? And my answer is, it's multifactorial. Unfortunately, many of them are lost to follow up. We have to remember there is parental autonomy. Patient, the mother or the father or both decide not to intervene. They were offered surgery. They decided not to intervene. And it may be because there is lack of trust. They perhaps don't trust the health system. But definitely lack of resources is a major issue, both for the institution on a governmental level and also for the patients themselves. Lack of access to care, the major center, think about it. If a child is admitted at Bustamante and they have to come from Montego Bay, they have that mother or that father or the parents, they have to worry about the traveling somewhere to stay for a prolonged period of time. So there are multiple things along the way that would cause that issue with access. And definitely I would say we do not have enough private-public partnership. And there are many reasons for this, and I think some of it has to do with too many red tapes at a governmental level that we need to look into and have ongoing discussion about. Because many people want to help, but there are too many roadblocks along the way. There is a lack of equity. A child in Kingston is not managed or of certain class, I don't think is going to be managed the same as somebody from the more rural parts. And we have to remember the financial constraints. Too few specialists exist to diagnose and treat. We get burnt out. So you have to consider when you have one or two cardiologists that's managing so many patients. Of course, after a period of time, you will get burned out. So you have to consider that. And many times that is neglected and people do not think about that. Unfortunately, as I said before, many of our patients are unaware of their diagnosis and interventions done. Unfortunately, I'm unable to retrieve some surgical notes. Some of these patients are done locally and some are done overseas. sometimes they don't know the center overseas that they did the surgery because it was done as a charitable event. Sometimes the parents are not available where the mother may have died and the child is not aware of the medical history. All they know is that they had a surgery done. And apparently, I've learned recently that the Bustamante, which feeds us some of these patients, I am not able to get some data because after a while, it's archived. And there is great difficulty in getting the information that is already archived. And there has been, unfortunately, some loss of records. So that, on my side of things, will pose a great issue, a great challenge. And of course, there is a lack of a local registry, which I'm hoping that we will change and able to update in the future. Now, cardiac surgeries are done in Jamaica. And I am quite surprised when I have conversation with colleagues at times and even with patients. They do not know this. And I'm not sure why, because why you would not know that we are offering cardiac surgeries. Yes, we are limited by expertise and we are limited by resources. There is a growing need, definitely, in the adolescent population for percutaneous interventions. So percutaneous valves, for example, for my tetralogy of follow repair, and they now need a pulmonary valve. There are a couple of trials now looking at even native valve implantation on these patients. And there's definitely PDAs. We do have a few of them who need closure. And there is also ASD, which these can be done non-invasively and by device closure. The issue though, not non-invasively, without open heart surgery for sure, and more of a percutaneous closure for these patients. We are still decades behind, I think. And the issue is cardiac surgery now.
Doc, apologies to interrupt. Remember, based on time, I'm going to ask you to help us out here and get close to wrapping up.
Nearly 9 decades. And all of this started with PDA closure and definitely cardiopulmonary bypass in the 1955. And interestingly, Jamaica started cardiac surgery from 1968. So the other thing I want to mention quickly because of time is adolescent athletes. Remember, sudden death of an athlete is devastating. And we have to think about HCM, hypertrophic cardiomyopathy, and arrhythmogenic cardiomyopathy for these patients. And we recommend routine ECG for athletes. And remember, an automated external defibrillator will save these lives. Now, the question is where to refer. In the public system, there is KPH or UWI, and there is Cornwall Regional Hospital. What subspecialty services are available? We do have electrophysiology services. We do have interventional, or we will have shortly, structural cardiology. And of course, we do have adult congenital heart disease services. And this is my last slide. The future direction, I want to leave and say it's hopeful. We need more public-private partnership. We need more trust and appreciation of our local experts. And we definitely need to invest in training our own people who will learn abroad, develop the skills, and return and teach our own people. And of course, we need to celebrate our success. Thank you.
Thank you so much, Dr. Reed. Excellent, excellent presentation. Very stimulating and some thought-provoking. So some thought-provoking issues that were brought there, which we discuss further. So moving right along, our anchor leg of sorts, in terms of our presentations, will be received by Dr. Sherard Little. He is definitely a friend to us pediatricians in the public setting. Dr. Sherrod Little earned his MBBS with honors in 1999 and his DM in cardiothoracic surgery in 2009, and an MBS in finance, all obtained from the University of the West Indies, Mona, Jamaica, West Indies. Following his cardiothoracic residency at the UA, he obtained a cardiothoracic fellowship at Cleveland Clinic, Cleveland, Ohio, from 2005 to 2007, and a congenital cardiac surgery fellowship at Riley Children's Hospital, Indianapolis, Indiana, from 2007 to 2008. Upon his return, he then served as senior registrar in cardiothoracic surgery at the University of the West Indies from 2008 to 2009, all of which better positioned him as a consultant cardiothoracic surgeon, offering his expertise at both the Bustamante Hospital for Children and the University Hospital of the West Indies, Kingston, Jamaica. Dr. Little has multiple peer-reviewed publications through not only local, but also international collaborations. Dr. Little is a philanthropist and serves on various boards as director or member, spanning a wide array of societies and foundations, in addition to guiding young medical minds as an associate lecturer at the University of the West Indies, Mona. A man with such an illustrious career also finds time for his passion, photography. He is the current president of the Jamaica Photography Society, where he shows off his mastered hand-eye coordination skills. Join us in welcoming Dr. Sherrod Little, an ever-growing work of art. That's nice. Dr. Little will take us through an update on pediatric cardiology surgery in Jamaica. Over to you, Dr. Little.
Thanks, Dr. Antoine. Good afternoon, everyone. Let me first say thank you to the organizing committee for inviting me to share on this platform with some very distinguished colleagues. I must say that I do have a special attachment with the Cornwall Regional Hospital, because it was the first hospital that I went to after completing medical school. So I did my internship at Cornwall Regional. So there's a very special place in my heart for Cornwall Regional and for the persons out west. I have no disclosures. This afternoon, I'm going to try and make up some time, but I'm going to look at some of the milestones in cardiac surgery in Jamaica, and then we will look at the current status of pediatric heart surgery with particular emphasis on the Bustamante Children's Hospital. So shortly after the opening of the University College Hospital, now known as the University Hospital of the West Indies, the first closed heart operation was performed by Sir Harry Adamontidu, and this was in fact a PDA ligation. So 1952, almost 70 years ago. Our first open heart surgery was done by Professor Michael Wooming. This was done April 9, 1968 at the University Hospital of the West Indies. And this was actually a patient who had an atrial septal defect. So you can see that congenital heart disease surgery was at the forefront of early cardiac surgery in Jamaica. Switching to Bustamante Children's Hospital, the first open heart surgery done at this institution was November 11th, 2000, and in the year 2000, and this was performed by Professor Howard Spencer and Roger Irvin. And as you know, Professor Howard Spencer is now our registrar at the Medical Council. This is a picture of that first patient on the first day after surgery, and pictured on the right of the picture, you'll see Professor Howard Spencer and a young Roger Irvin. And on the left of the picture, I think there are some representatives from Quartz who helped to sponsor the refurbishment of the operating theater that this surgery was performed in. So in terms of milestones, surgeons, we have to acknowledge several persons in different specialties. On the surgical side, we have Professor Paul Ramphal and Roger Irvin, who is pictured here. In terms of our pediatricians and our pediatric cardiologists, Dr. Colin Millard, Dr. Keith McKenzie, Dr. Doreen Millard, Dr. Priscilla Morales, Charmaine Scott, who you heard presenting earlier, Dr. Sandra Williams-Phillips, and Dr. Russell Chator. We have also collaborated very closely with our adult cardiologist, and we have Dr. Christian, Dr. Professor Denbo, Professor Besterman, Dr. Chung, Dr. Mohammed, the late Dr. Foster, who is pictured here, and Dr. Andreen Chung. Very important as well, our anesthetist, Professor Siva, Dr. Mina Scarlett, and McGaw, who carried the baton at University Hospital, and then Dr. Lambert Innes, who is pictured here at the Bustamante Children's Hospital, Dr. Ika Metalor, and Dr. Brian James. And we can't leave out our perfusionists, Mr. Fitzhugh Forrest and Miss Dorothy Pinnock, both from the University Hospital. Now, our history in terms of cardiac surgery is twinned with clinical partnerships. And these partnerships have been very important in the development of cardiac surgery in Jamaica. One of these organizations is the Chain of Hope charity, which was founded by Sir Mahdi Yaqub, a very eminent cardiac surgeon who started with missions to Jamaica back in 1996, initially to the University Hospital, and then to the Bustamante Children's Hospital with over 400 patients being treated. Professor Victor Sang, also a member of the Chain of Hope team, and he was actually just here last week assisting us with some very complex operations. There are other charitable groups that have partnered with us here in Jamaica. The Caribbean Heart Menders, founded by Brenda Scott, who is pictured here, started again with missions to the University Hospital in 1997 with over 150 procedures performed. Pictured here is Professor Richard Besterman, who initially came with the Caribbean Heart Menders, and then with his own organization, Jamaica Children's Heart Fund, he himself performing over 200 procedures here. And I consider Professor Perriman as partially Jamaican as well. He's here ever so often. And then more recently, we have the Cardiac Kids Foundation of Florida, founded by Professor Jeffrey Jacobs, having done over 121 procedures here in Jamaica. Now, in reviewing the first 35 years of cardiac surgery in Jamaica, this paper written by Marina Scarlett et al. Documents the early history of cardiac surgery between April 1968 and June 2003. Over this period of time, over 2,200 patients underwent cardiac surgery. 37% of these were valve operations, 25% were PDA ligations, and in addition to the PDA ligations, you had another 24% of patients who had congenital heart disease. So you can see that patients with congenital heart disease made up almost 50% of the initial operations which were performed during our early history. What is significant, however, is that in the same period of time, with over 500 operations being done for congenital heart disease, 80% were done by visiting teams. So where are we today? Well, cardiac surgery, pediatric cardiac surgery is done primarily at sites in Kingston. The Bustamante Children's Hospital is a main site for congenital heart surgery. I would say more than 95% of operations are done at this hospital. The University Hospital as well does a few cases, and a few cases are also done in private institutions. But by far, The institution that performs the majority of congenital heart procedures is the Bustamante Children's Hospital. In April 2019, a cardiac unit was opened at the Bustamante Children's Hospital. It's pictured here on the right. It includes an operating theater, a cardiac catheterization laboratory that has a biplane cath lab, and a 10-bedded intensive care unit. In terms of the cardiac team at Bustamante, we have 2 pediatric cardiologists. You heard from both of them earlier, Doctors Forrester and Dr. Tomlinson Morris. We have 1 cardiac surgeon, yours truly. We have 1 cardiac anesthetist. Pictured here is Dr. Cleopatra Patterson, who is ably assisted by several postgraduate anesthetists who become very proficient in cardiac anesthesia. Currently, we have 1 perfusionist, and we share critical care nurses with the general pool at the hospital. Now, what are the types of procedures which are done at the Bustamante Children's Hospital? In terms of closed heart procedures, we do ligation of patent ductus arteriosus, we do coarctation repair, and we also do aortopulmonary shunts. Pictured here on the right was a child who had his coarctation repair done at about 11 days of age. This young man is now in high school at Titchfield. In terms of open heart procedures, we do atrial septal defect closures, ventricular septal defect closures, repair of atrioventricular septal defects, tetralogy of Fallot repair, and bidirectional Glenn shunts. And there are some other smaller procedures which we also do from time to time. What don't we do? At this point in time, we don't do the arterial switch. So for patients who are born with transposition of the great arteries, these patients, upon diagnosis, are usually prepared for export. We don't do the NORD procedure. So patients who are born with hypoplastic left heart syndrome or any variation of this are usually treated medically. And we don't frequently do truncus repair either, but we don't see very many patients with truncus. In terms of TJs, we probably see maybe 3 or 4 patients with TJs per year. A similar number of patients are born with hypoplastic left heart syndrome, and truncus repair or patients with truncus arteriosus are infrequently seen. So let's look at some of the data. And I reviewed well, even before we start looking at our waiting list, what we can confirm is that we have close to 150 patients who are awaiting surgery. And this graph shows a basic breakdown of the major lesions that these patients who are awaiting surgery have. So 8 patients awaiting ASD repair. Largest proportion of patients have ventricular septal defects. About 53 patients awaiting surgery. Then we have AVSDs, tetralogies, coarctations, valvulopathies, and then some smaller groups going down. What is significant, though, is that some of these patients, I say these are the patients who we can confirm, who we are still in contact with. Quite a few patients are lost to follow-up. Some patients do get intervention overseas, while others are outside of the system and we're not sure exactly what happens to them. Now, in terms of our data, we reviewed our outcomes over the last 8 years between 2015 and 2022. And over this period, over this 8-year period, 283 operations were done. Now, you can see that coming from 2016, there's a gradual increase in the number of cases being done. Now, 2017 marked a point where we started utilizing the operating theater in the new cardiac unit. And we all know what happened in 2019. There's a COVID pandemic, and what this resulted in was a closure of our cardiac ICU. So we again had to go back to our post-operative patients being housed in the general ICU and competing with all the other patients needing ICU care. So it made it very difficult to get elective cases done. In fact, during the period of the pandemic, we reverted to doing mainly emergencies and urgent cases. And some of these emergency and urgent cases were of the highest complexity. So you see that going from 2019, 2020, and 2021, there's a decline in the number of cases that were done. But last year, we were able to get back up to speed again, partially because we got a break in terms of COVID. And also, in addition to that, last year, we also started hosting visiting teams again. So teams started coming back to Jamaica, and this allowed us to do more cases and not rely on the availability of ICU space in the general ICU. This graph represents the weight distribution of patients over this period of time. Approximately 20% of the patients who are operated on were less than 5 kilos. And it's probably evenly split between the groups. The greatest proportion of patients, 31%, were greater than 20 kilos. The second most common group was anywhere between 10 and 20 kilos. But we do a significant amount of patients who are less than 5 kilos, which is about 20% of the population. And I will discuss later how this affects outcomes in our patients. In terms of our mortality data, it has been up and down over the last 8 years. In 2022, we had the lowest mortality over the 8-year period, with a mortality of 4.2%. But as I said, it has been up and down, and there are various reasons for this. I think the next slide will demonstrate the reason for this. Our highest mortality has been in the group of patients who are less than 5 kilos. You can see a unacceptably high mortality of almost 27%. Once patients are greater than 5 kilos, then the mortality rate significantly decreases. In the 5 to 10 kilo age group, 6.5%. It's lowest in the group of patients who are between 10 and 20 kilos, 1.3%. And then it increases slightly in older patients or patients who are a little heavier, 20 kilos or more, 4.6%. Now, this slide is very telling because it shows the mortality data based on the type of procedure which is done. And patients who had aortopulmonary shunts had a mortality rate of almost 38%. Now, patients who had more aortopulmonary shunts were usually patients who presented with problems in the neonatal period. They were less than 5 kilos, and they usually had a very complex cardiac disease. The following slide will show you what the disease spectrum looked like. For patients who had ASD closure, there's 0% mortality. For complete AV canal, 0%. For tetralogy or fallow without a transannular patch, it was 0%. For patients who had VSD closures, it was 3.6%. for patients with coarctation repair, 4%. And then for patients who had PD ligation, 4.9%. Now, when I saw the mortality for PD ligation, I found it a little strange, quite disturbing, in fact. So I had to go back and look at the data. And there were actually 2 patients, and these 2 patients had other congenital lesions in addition to their PD. So one patient had a very large VSD and actually underwent PD ligation and PA banding and died in the ICU 8 days later. And then there was another patient who had a PD and an apical VSD who died at postoperative day 14. So although the PD ligation mortality data is a little striking, there are reasons for that, in that these patients had multiple pathologies. Now, going back to the data on aortopulmonary shunts, these patients can be very challenging. I'm sure my anesthetic colleagues from Bustamante can attest to that. Looking at the 9 deaths that we had over the 8-year period, 7 of the 9 patients were less than 4 kilos. I don't know the weight of one of the patients, so it could well have been 8 of 9 patients were all less than 4 kilos, so they are quite small. They also had complex anatomy, and what is listed here is the anatomy that these patients had. So quite a few of these patients had pulmonary atresia, tricuspid atresia, and this could have been combined with other pathologies as well. So a very complex group of patients to deal with, leading to the high mortality of patients who underwent aortopulmonary shunts. So what about the mission teams? In terms of missions or visiting teams, our focus has shifted from having teams come in and just do cases and leave to training of local staff. So there is knowledge transfer at all levels, from perfusion to critical care nursing or operating room nursing staff or anesthetists or surgeons or cardiologists. So basically when a team comes, team members are paired with their local counterparts, and there is knowledge transfer and skill transfer between the teams. So much so that the team composition has now been adjusted based on the local needs. So for example, in the past year, in 2022, the visiting teams consisted mainly of ICU nurses and intensivists, because our major challenges in this area where a lot of our nurses have migrated, they have left the system, and so that we don't have enough nurses to care for our patients in the perioperative period. So much so that for the majority of 2022, no visiting surgeons came because the cases were managed by the local surgical staff. These teams are also important as well because they provided a significant support of cardiac disposables. Unfortunately, our hospital, although it is making efforts to try and take on purchase of disposables, they are not up to speed at this point in time. Cardiac surgery is extremely expensive, and I think our healthcare system is just coming to terms with that now. So in summary, in terms of pediatric cardiac surgery in Jamaica and Bustamante Children's Hospital, the program there in particular, I would say the majority of patients with congenital heart disease can safely be treated in Jamaica with acceptable outcomes. However, careful patient selection is key in ensuring good outcomes. I'm sure we'll get into this discussion as we have the ethics discussion coming a little later on. Personally, I believe in doing the good for the greatest number of persons. And there are some patients with very complex anatomy where you have to ask yourself the question whether it is in the best interest of the majority of patients that you take on certain complex patients, because they will eat through your resources, and the long-term palliation is not great. Yes, the question is asked, can you do the surgery? Yes, we can do the surgery, but should you do the surgery? Is it in the best interest of the greatest number of patients? We continue to rely heavily upon overseas partners, partner missions to supply particular personnel and disposables. And finally, greater emphasis has to be placed on training and retention of human capital. The fact is that we have skilled practitioners throughout all the specialties. We need to continue to retain these persons in Jamaica so that we can serve our patient population to the best of our ability. I thank you very much.
Thank you so much, Dr. Little, for that detailed perspective into pediatric cardiac surgery in Jamaica. We definitely have come a long way, but we still have a ways to go. But good work from you and your team, and we can't overemphasize the contribution from our visiting mission teams. They have helped considerably, but it's good to see that emphasis has shifted towards training for persons locally and trying to retain those persons within our system. Thank you, Dr. Little, again. Dr. Tracy Gilbert says, thanks for highlighting, I think she was referring to Dr. Reed here, thanks for highlighting the access to care issues for out-of-towners, long surgery waiting lists as well. Some children become inoperable after waiting or even worse. And this is an important consideration and has to change with this wonderful team of cardiologists. Thanks again, Dr. Little. So I remind you to continue posting your questions in the Q&A session. Everybody's saying excellent presentations. So now I will jump into in the interest of time, a video presentation from one of our sponsors from Abbott.
You promised to give your preemie the best start, to help them catch up on the outside and on the inside. That's the promise of Similac. But there's more to growth than weight and length. Similac NeoSure is designed to help with development you can't see. Compared to term infant formulas, NeoSure is enriched nutrition for preemies, including increased calcium for growing bones and increased protein to support catch-up growth. It also has DHA and ARA to nourish baby's brain and eyes. As the most extensively studied preterm post-discharge formula, Similac NeoSure has been shown to promote growth and development of preemies when fed for the first full year. So, to help support excellent catch-up growth on the outside and important development on the inside, count on the promise of Similac.
Through decades of research on infant nutrition, we've focused on a special type of prebiotic. HMOs, or human milk oligosaccharides, are one of the most well-studied components of breast milk. Abbott has contributed to this research for over 25 years. HMOs are the only major prebiotics found in breast milk and the most abundant solid component after lactose and fats. HMOs have unique structures, and emerging science suggests that they can work in unique ways other prebiotics cannot. We know there are 3 categories of HMOs: acetylated, fucosylated, and sialated, or A, F, and S for short. Within those categories, these are 5 of the most abundant HMOs commonly found in human milk. Each HMO not only has a unique structure, but they're also believed to serve different functions for brain development, immune support, and digestive health. Preclinical research suggests that HMOs support digestive health. HMOs selectively support the growth of beneficial bacteria in the gut. And HMOs may also support the developing immune system. In cell culture, each HMO acts as a receptor decoy to block specific pathogen attachment. This means that different pathogens attach to the HMO decoys instead of the epithelial cell's walls, which helps block adhesion. In preclinical data, the unique structures of specific HMOs allow them to bind to immune cells to support a more balanced immune response. Preclinical research also suggests that HMOs play a beneficial role in brain development through communication via two pathways, circulation and the vagus nerve. In the first pathway, fucose, sialic acid, and microbiota-derived metabolites are absorbed into the bloodstream where they can travel to the brain to support cognitive development. And in pathway 2, these metabolites and 2-FL-HMO may activate the vagus nerve, which stimulates the developing brain. Human milk concentrations of 2-FL and 6-SL-HMO have been associated with measures of improved cognitive outcomes through 24 months of age. To recap, just remember 3-5-3. There are 3 categories of HMOs. Within these categories, these are 5 of the most abundant HMOs, and different HMOs may help support 3 functions: digestive health, the immune system, and brain development. It's becoming clear. Preclinical research suggests that HMOs play complementary roles to power the gut-brain immune axis in ways that are unlike any other prebiotic. Abbott is a leader in HMO research, and we are excited to continue bringing new innovations to infant formula.
Thank you to our sponsors at Abbott. So we have 2 questions that we will entertain quickly. This one is for Dr. Reed. Are you still there? This is from Dr. Tahira Redwood. She says, Dr. Reed, our panel, how can we get funds to cover costs of percutaneous interventions?
Not sure if Doc is here. Doc, are you there? I know Doc has been with us all morning, early. I can imagine that maybe he has had to run to deal with something as an emergency. Perhaps we could ask the next question to Dr. Little and hope that Doc comes back in time. Oh, there he is.
Here he is. Did you heard the question, Dr. Reed?
Sorry, I didn't hear that. Sorry about that. I had
Okay.
an emergency call. That's
No
all.
problem. We understand. So the question was, how can we get funds to cover costs of percutaneous interventions?
Well, that's a great question. I wish I have that. I wish I had the answer and more so. I wish I had the box to do it. But definitely it's a growing need. And we are doing a lot more percutaneous interventions, definitely. You know, as opposed to the open heart surgery, definitely for the adolescent when they cross over to us for sure. There are couples that we need, like PDA closures can easily be done percutaneously. ASD closures can be done. The government do have some funding. It's limited. You know, and I mean, and it takes a very long time as well to access the funds. Currently, there is a private institution that does some amount of percutaneous work, but the cost is very prohibitive to many of the patients who actually need it, and that's the problem. So I do try and send in a letter to the government as much as possible. To be honest, it's very, a lot of time it doesn't work out. But if we can try and do more private public partnership, I think that is the way to go. There are couple persons have reached out, or you know, companies or entities have reached out that they would like to help, but there are just too many red tapes in the government system, which, you know, is a whole different thing to go into. But I think that definitely if we want to afford it, we have to get a public-private partnership for that.
Well said. Thank you, Dr. Reed. The other question, I believe, was answered on the chat by Dr. Little. I'm not seeing it anymore. I'm hoping that it was answered and the person received the response that
Dr.
they wanted.
Antoine? Right, Dr. Little here again. I just want to add to Dr. Reed's response. Although some of the simpler lesions can be corrected without surgery, sometimes it is more expedient to go the surgical route because in terms of the timeliness of the persons getting an intervention. So some ASDs and some PDAs can be closed percutaneously, but the amount of time that the patient is going to wait and the cost in terms of the devices, sometimes it is cheaper to have these lesions sorted out surgically than to wait for percutaneous intervention. Hopefully that will change with time, but sometimes we have to do things in the best interest of the patient. So if they're left with a scar and they get their intervention done in a timely manner, then that may be better than waiting for an intervention, which is going to result in long-term morbidity.
Sorry, if I can just interject there. I totally agree with you, Dr. Little, for sure. And I definitely refer those, that can go to the surgeons. The issue is many of these also have complex congenital heart disease and complex other medical issues. Like one patient, she's 32 years old, but she's also had stroke and she also had some other spinal issues as well, which, you have to factor in everything. So would you prefer percutaneous approach versus, putting this patient on a cardiopulmonary bypass with its complications? So I do assess the patients. And definitely, if it's straightforward, I do send straight to the surgeon. But unfortunately, in the congenital world, nothing comes that simple.
This is true.
Okay, so thank you for both your responses. And thanks again for your presentations. We must move on. And this year, our awardee is Pediatric Nursing Supervisor, Sister Cassandra Watson. And let's watch this video.
Good afternoon, everyone. It is truly an honor for me today to be presenting the Distinguished Pediatric Service Award to my colleague, and might I dare say my friend, Sister Cassandra Watson. Sister Watson was trained at the Cornwall School of Nursing. She started working at Cornwall Regional Hospital in January 1997, and in July 1999, she was assigned to the pediatric unit. She subsequently applied for and was selected to study pediatric nursing in 2003. And on completion, she was assigned as charge nurse of the pediatric medicine unit. In 2014, she completed another course, this time in nursing administration. And on completion, she was assigned as nurse manager for the pediatric unit. Presently, Sister Watson is assigned as acting departmental manager for the special care nursery, pediatric medicine and surgery, and the psychiatric units. In total, Sister Watson has worked in the pediatric unit for 21 years. Can we hear a big round of applause for today's recipient of this distinguished award, Sister Cassandra Watson.
And so what we have for you is a little slideshow of Sister Watson. Hard at work and being celebrated for her hard work. Congratulations, Sister Cassandra Watson. Round of applause, everybody. Can I see some ones in the chat? Bigger up. There we go. And now we're going to actually ask Sister, I believe she's on, if she would like to say a few words. Let's see if she's on here. Yes, here she is. Sis Watson, unmute for me, please. Sister Watson, are you seeing a pop-up asking you to unmute? I think she's overwhelmed with joy, perhaps in her celebration has walked away a little bit. All right, so we definitely will come back to Sister Watson when she's available. I think now I hand back over to you, our moderator, Dr. Antoine, and we'll take it from there.
Okay, so a hearty, oh, here is Sister. I think she's on now.
Hard at work still, it looks like.
Sister, congratulations to you. You may go ahead.
Good afternoon, everyone.
Good afternoon, Sister. You may go ahead.
Good afternoon. I'm finding a quiet place because I'm presently at the funeral of one of our patients that passed from the pediatric unit. So I'm trying to find a quiet place. All my colleagues on the pediatric unit, I am truly honored and I am truly who have recognized me as such. Paediatrics is I into nursing. My grandfather, way back when I was a little girl, assigned me and appointed me as nurse. You will be a nurse for children. And I think I have honored him in doing such. I came to PEDS as a nurse and quickly recognized that that was where I want to spend my time. And I am truly honored that I've been recognized as such. And I want to thank all of the pediatric unit at the Cornwall Regional Hospital. I do appreciate what you have done, and I look forward to going into our new hospital, right, everybody? I'm truly looking forward to that. I'm going to a new pediatric hospital, and I know we'll be a force to be reckoned with. So thank you once more to all my members of the pediatric team at the Cornwall Regional Hospital. You have made my work easy, and I can remember us being the main hospital, what a close-knit group we were, and I know we can get back there despite all that is happening now with us being spread wide and far, that we're looking forward to having that kind of team again. So thank you once more. Thank you so much. I really feel honored. Thanks a lot.
Thank you, Sister Watson. Well deserved. And condolences on the loss of your patient, and condolences to the family. Okay, so moving along, I will actually hand over the reins to the next moderator. So my time here is finished with you all. Thanks for your attention, and please continue to remain online. We have an interactive session coming up, but I will hand over the reins to Dr. Patrice Monroe. He will continue on with the last session. Thank you so much.
Good afternoon, and thank you, Dr. Antoine. Good afternoon, everybody, and welcome to the final leg of today's symposium, the final lap. I'm sure you'll all agree that we've had an excellent session, and let me extend my congratulations to Sister Watson on that award. So I want to say that the final session that we have this afternoon is on ethics. So the importance of ethics in medicine. Why is it important? It's important because it ensures our patients receive appropriate care. It protects our patients' autonomy, privacy, and provides guidance for difficult decisions involving medical treatment. Now, more specifically to our pediatric patients, they're particularly vulnerable as they need our protection, as the treatment decisions that are made can affect them long-term and have long-term consequences. So at this point, I want to introduce our distinguished panel of experts that will help us navigate some of the ethical challenges surrounding the pre- and postnatal diagnosis of critical cardiac lesions. I want to welcome back to our panel discussion, or welcome to our panel discussion, Dr. Juanita, sorry, let me just get it, Dr. Juanita Hunter, welcome back, and also Dr. Shar Little. Congratulations on excellent presentations. I'd just like to say good to see my classmate, Dr. Little. It's been a long time. Welcome back. And before I continue, new to our symposium this afternoon is Dr. Leroy Walker. So let me say a little bit about Dr. Walker. Dr. Walker achieved his Bachelor of Medicine and Surgery from the University of the West Indies in 2011. He subsequently went on to pursue his DM in obstetrics and gynecology, and that was completed in June of 2018. And subsequent to that, he also went on to complete a fellowship in maternal fetal medicine, and that was between 2019 and 2021, right in the COVID pandemic. So great congratulations. I would like to say that Dr. Walker has some special skills. He is one of only 3 certified OSHA providers in Jamaica. And of course, with his specialty in maternal fetal medicine, he consults for high-risk pregnancies. So just to finish, Dr. Walker has consults with his patients out of Westminster Medical. And his objective is to continue to provide outstanding holistic care with a detailed and dedicated approach while maintaining communication and confidentiality. So welcome to our panelists. And I'd just like to say that as we start today's discussion, I will be essentially, sorry, just give me 1 second here. I will be directing questions to the different panelists. However, please feel free to weigh in despite me directing them to the different panelists. So I want to start by a quick question, and that is, what are the critical cardiac lesions that pose a challenge at antenatal screening? So I want to pose this question to our pediatric cardiologist, Dr. Hunter. If you could just give us an overview of some of these cardiac lesions. Over to you, Dr.
Thank you, and thank you for the introduction. I've enjoyed the conference so far, so I appreciate the opportunity to be here, and also the opportunity to be here on this ethics panel. I'd like to correct one thing you said. I wouldn't consider myself an expert as yet. I'm still learning, but you know, we're all here together. So in terms of the lesions that pose a challenge at antenatal diagnosis, I'll start by saying there's some lesions that are easier to detect on the antenatal screen, i.e. those lesions that show themselves readily on the 4-chamber view. So along the more severe end of the spectrum of hypoplastic left heart syndrome with mitral and aortic atresia, where there's no discernible LV cavity and a single right ventricle, you know, the detection rate is going to approach 100% as long as the other factors involved in the quality of the imaging are favorable. In the 4-chamber view as well, pathologies such as truncus and tetralogy that have a large conoventricular septal defect with the semilunar valve overriding the crest of the ventricular septum are going to be more readily detectable on that view, which is part of the anomaly scan. And so those lesions tend to have a higher rate of detection. Coming down to the difference between a truncus and a tetralogy with pulmonary atresia, for example, can be difficult because that involves a more detailed examination of the branch pulmonary artery anatomy. And, lesions involving the systemic and pulmonary veins, for example, total anomalous pulmonary venous return has a pretty low detection rate because it involves a detailed exam at the pulmonary venous anatomy to show that they do not enter the left atrium, that they form a confluence behind the left atrium and may either ascend vertically or descend to drain below the diaphragm. And so that particular lesion is usually detected postnatally, but can be detected antenatally with a careful exam, but tends to be picked up more in those patients who have associated cardiac anomalies, for example, in our patients with heterotaxy who may have unbalanced atrioventricular septal defects with varying degrees of ventricular hypoplasia. Critical congenital heart lesions that involve primarily the outflow tracts, and the anatomy of the outflow tracts are going to be more difficult to detect antenatally. Coarctation of the aorta is another Achilles heel for us, in that the aortic arch may not appear, especially the isthmus, if it's just isolated, discrete coarctation at the isthmus may not be easily detectable antenatally. You may have secondary clues such as right heart dilatation. So we always suggest that if the right heart is dilated, a detailed exam of the arch is also performed. And even postnatal, we have patients who are born with a dilated right heart or a borderline small isthmus, whom we allow the ductus to close to see if coarctation is going to manifest in those patients. So I would say the lesions that are primarily where the outflow tracts or the great arteries are primarily involved can be particularly difficult to detect in utero unless there is a careful examination of the outflow tracts.
Thank you, Doc. Thanks. And I want to address the next question to Dr. Walker. Antenatally, how frequently do you come across some of these lesions, and some of these syndromes? Are they more common? I don't know if you can give us an idea of the frequency of these lesions.
Good afternoon, and thanks for having me. As Dr. Hunter rightly said, the majority of the lesions that are easily detectable are those which are visualized primarily on the four-chamber view. Hypoplastic left heart, as you mentioned, is one of those big lesions which are very easily and readily identified, but it's important to recognize that there are numerous other factors which may reduce the sensitivity of detection. Now, obesity is not just a problem locally, but worldwide. You'll find that obese patients, the quality of the images that are produced are significantly reduced, and that can sometimes affect the images that we actually obtain at the time of the anatomy scan. For this reason, we often ask our patients who are of a larger body habitus to possibly come in a little bit later to have repeat scans done at a later gestational age, sometimes 24, 25 weeks, when these structures are a lot bigger and definitely more easily and readily visualized. Numerous studies would have shown that patients first, second versus third trimester is a significant improvement in terms of sensitivity of detecting these lesions, again, because the size of these structures, predominantly the heart, increases. The other thing we'll have to recognize is that majority of these anatomy scans are not necessarily being done by pediatric cardiologists or maternal fetal medicine specialists. The general radiologists are doing a lot of these scans, and therefore the ease of detection is going to be, dependent on the level of individual who's performing the scan at the time that the scan is being performed. You'll also find it dependent on the level of risk of the patient that will often affect how likely it is that these defects are detected. For example, high-risk patients with pre-gestational diabetes, collagen vascular disease, patients with known congenital heart defects or known aneuploidies. These are patients where there's a higher index of suspicion. These patients may often be either referred to an MFM specialist, or there's a higher degree of looking specifically for these lesions. So you have the body habitus, the level of risk of the patient, the type of lesions, the view that the lesions are more visibly recognized in. Generally speaking, though, I would say lesions which are more likely to be viewed in the four-chamber view, on average, have detection rates which approach around 70 to 80%. And this is significantly higher than those detection rates seen in lesions which are visualized on either the outflow tract views or the vessel tracheal views, which can be as low as around 20%. And again, these things will vary dependent on those other factors. In terms of how common these lesions are, what I would say is the most common congenital heart lesion, which is not necessarily a critical cardiac lesion, are ventricular septal defects. I mean, incidences probably range around 30 to 50% versus something like a hypoplastic left heart, which approach probably around 3 to 4% in terms of percentage of congenital heart defects which are seen. Transposition tetralogies usually range around 1 to 2% in terms of how often we see them. So definitely you have your ventricular septal defects, patent ductus arteriosus, atrial ventricular septal defects. Those are usually among the most common ones, and what we often see associated with aneuploidies, which are predominantly a lot of the patients that we receive in the maternal fetal medicine clinics.
Okay. All right. Thank you, Dr. Walker. And you mentioned some of the aneuploidies. I guess the trisomy is 13, 18, 21. Are we seeing any particular shift or increase in these types of conditions or syndromes?
Well, definitely. What I would say is, even though majority of these syndromes occur in women that are not advanced maternal age, just because the proportion in terms of those numbers of patients, pregnant patients, are usually more, we do have a shift in terms of the trends in maternal ages that we're seeing. We're seeing a lot more patients over the last couple of years presenting age greater than 35 years, and even more commonly now age greater than 40 years are presenting and who are pregnant. And therefore, invariably, the risk of a lot of these aneuploidies and associated congenital heart defects will increase as a result. So there has certainly been a slow and steady increase as the average maternal age increases. A lot of women are delaying their childbearing desires or childbearing until completion of career and other things. So you find a lot of patients who are presenting age greater than 35. Of course, as the age or maternal age increases, so does the increased risk of certain comorbidities, diabetes, for example, which poses a significant risk in terms of onset of aneuploidies.
All right, thanks, Don. Okay, let's delve into some surgery. So this question to Dr. Little. Essentially, what can we expect in terms of the surgical outcome versus medical treatment versus the untreated patient in terms of life expectancy?
In terms of a particular lesion?
In terms of some of these critical lesions. So I would say the surgical management, if there was one, versus medical versus no treatment at all. What can you probably say or add to the approach, that type of approach? It's a little broad question, I know. I know there are particular ones, but if there's any comparison for those lesions where there is the option to, or maybe perhaps not even the option, but we have to use maybe something palliative or something like that. What's the expectation in our setting?
I think the expectation is gonna vary between various settings, whether you're in a first world setting or whether you're in a third world setting, such as ours. A lot of the critical lesions where you have a single ventricle physiology are extremely difficult to manage in our kind of setting, because these patients are going to need quite a few of them will need neonatal interventions. So shortly after birth, which are associated with high mortalities in a third world setting. A lot of these patients will require multiple interventions, whether surgical or catheter-based intervention, over their lifespan or early childhood. And most of these patients will need a very close follow-up as well, because once they get into their teenage years, then you start seeing a lot of the complications, especially those patients who have undergone single ventricle palliation with Glens and Fontans. So usually my approach to when these patients present or when I sit down with the discussion with the family is to try and outline what their expectations are going to be in our setting. That, in terms of treatment of their child, this is going to be a long-term issue. It's nothing that we can fix. I always tell my patients that for the most part, I don't fix anything. What I do is try and palliate. There are very few lesions in cardiac surgery where we actually cure. So for the most part, we are palliating, relieving some of the symptoms. And it is after outlining the potential outcomes in terms of what to expect, then I also let our parents know that it is okay to do nothing. It is okay to have comfort care and medical care and not have surgical intervention. What I do find though is that a lot of parents, once you indicate that there is a possibility of surgery or some sort of intervention, they are going to tell you, well, doc, if there's a chance, just do it, just go ahead and do it. So even though the risk may be significant, I find that a lot of our parents want to do something for their child. They don't want to, medical care alone or comfort care alone is not acceptable to a lot of our parents and their families.
Okay. All right, thanks. And Dr. Hunter, I just want to ask you, you had made mention of some of these, the critical lesions, the larger vessel lesions. So I wanted to just ask about, in your experience, life expectancy, I know it's going to vary from, and depending on a number of factors, but what can you say about life expectancy for some of these critical lesions?
So again, to second Gerard's point, it depends on the setting. Where I'm practicing now, which is a first world country, the majority of diagnoses now are made in utero during fetal life, either because patients are sent to us because of an abnormal antenatal scan, or they're sent to us directly because of their risk of having a child with congenital heart disease, for some of the disorders that Dr. Walker mentioned earlier. And then when we make the diagnosis, we coordinate the care along with the neonatologist and other subspecialists who are going to be involved in the care of the patient. So the care begins in the antenatal period. The delivery is planned such that the baby is born in a center that's able to provide the care that's necessary in the neonatal period in order to ensure optimal outcome. And then depending on the lesion itself, and then within that lesion, the spectrum of severity of the particular disease, then that would determine the outcomes, as well as associated comorbidities. For example, we have patients who, a hypoplast who is born at term 3 kilos, no other comorbidities with good ventricular function, and one who is born preterm at 34 weeks at 1.5 kilos, the outcomes are going to be very different, as prematurity and low birth weight portend a poor prognosis for these patients. So we try to get them to term as much as we can, to at least 39 weeks gestation, and then deliver. And then in terms of the overall outcomes, some I had mentioned in the presentation, transposition, because of the experience over the years, particularly after the arterial switch by Jatent, we have excellent outcomes, upwards of 97% survival, just straightforward transposition intact ventricular septum. Lesion or single ventricle physiology patients, for example, those with hypoplastic left heart syndrome who have gone through Fontan palliation, at best, in terms of the 20-year survival, we have now reports of up to 80% survival. Knowing that these patients are palliated and will require a transplant at some point, they will not live, well, so far in our experience, because of the complications associated, they will require a cardiac transplant. They cannot continue through life just with the single right ventricle. TAPVR survival is quoted up to 86%, coarctation, excellent survival after neonatal heart surgery. And now because of increasing experience, that surgery may be the only intervention that many patients need. Just that coarct repair in the neonatal period, even though they do require lifelong cardiology follow-up, for the complications of recurring coarctation, aneurysm at the coarctation site, hypertension later on in life. So all of these patients will require lifelong care, but the outcomes generally through the years have been improving with increasing experience, of, yes, surgical expertise, but also the expertise of the medical team involved in the care of these patients from fetal all the way through to adult life.
Thank you, Doctor. And Dr. Little, do you think that the availability or lack of availability of surgical care post-delivery affects life expectancy in these patients?
Most definitely. Unfortunately, or even in terms of elective patients, surgery is usually delayed. When we go based on the recommendations in terms of even very simple lesions as to when to intervene, we find that a lot of our patients are getting their interventions outside of the recommendations. So that does affect the possibility of complications later on and problems later on.
Yeah. And I know you mentioned in your presentation that we've been hampered by, some of our critical care nurses going overseas. So I guess leading on from that, just a supportive ICU care, because I know a lot of these cases require the team always to support them. So well, I guess you said that also poses a problem going forward as well. That was going to be my next question in terms of the expertise and resources, but I think you would have mentioned that. So just to recap, I think you said that it would have hampered the availability, if I'm right, please correct me, to provide services. And I don't know if you said that we're back on track now, were we?
I wished we were, but even very simple lesions, when I see a patient with a PD or VSD who develops Eisenmenger's in this day and age, it really pains my heart, because these are really simple lesions that we can handle here. But for various reasons, either they present late or they're in our system, but they have delayed interventions because we just don't have enough capacity within the system. So, even before we get to the complex things like single ventral physiologies, the simple things we really need to get right, because we can do those things. So we just need to develop the capacity within our system. And it really comes down to human capital, or nurses, or intensivists, or anesthetists, surgeons, cardiologists. We need to keep that human capital here so that we can manage these patients, because the majority of the patients we can that present to us, we can manage in our system.
Thanks. Okay, let's segue into something a little, legal frameworks based on recent politics in the U.S. and also, some might term the laws here. We would have studied when we were specializing that Jamaica has restrictive laws when it comes to restrictive abortion laws, so to say. So I just want to ask how their specific laws, how they affect our approach or the management of these, especially if they're critical or if there's a poor chance of survival in these patients. How is this affecting how we manage the patients, how we counsel the families? Dr. Walker, in terms of our legal framework in Jamaica, I don't know if you face any challenges there.
Well, what I would say is the current laws do allow for medical terminations, providing that it's a fetal anomaly which is non-compatible with life. Now, I mean, this could be approached in several ways, in that there are a lot of these critical cardiac lesions which technically are not incompatible with life. Life expectancy is extremely low. and significantly reduced in terms of morbidity and mortality, particularly if they're uncorrected. However, a lot of patients who we do see who have congenital heart defects, there's a 50% association of congenital heart defects with underlying aneuploidies. And a lot of these fetuses will have extra cardiac manifestations and therefore not just possess these congenital heart defects, but also have other defects in other organ systems, which will invariably reduce the prognosis and therefore render that fetus now incompatible with life. So it's not just the cardiac anomalies or the congenital heart defects themselves, which may, make the fetus incompatible with life, but no, the multiplicity of abnormalities that we visualize on the scan. The other thing that we have to take into our current context locally is, as Dr. Little mentioned, the unavailability or the lack of the necessary resources which we may possess in terms of staffing, equipment, to perform a lot of these procedures which may be necessary to improve life expectancy. So I don't think from our point of view we necessarily pose, that the current laws necessarily pose significant challenges. But how we usually counsel patients is we tend to give them options. A patient presents, they have these defects which we may have detected. We perform the scan, complete anatomical survey to look for any other associated abnormalities. And if they're found, we usually adopt a multidisciplinary approach involving our specialists from the pediatric aspect as well. And we'll have meetings to discuss what is the likely prognosis given the type of resources that they have currently available. What sort of care can be offered, and based on that, we can counsel the patient appropriately in terms of offering medical termination at that time based on the prognosis, as well as we just continue monitoring through the pregnancy in terms of doing serial scans, taking into account that a lot of these fetuses are at risk of intrauterine growth restriction, preterm delivery, as well as intrauterine demise, as well as even explaining to them that even if the child is delivered at term, based on the current abnormalities that we're visualizing, even in the best centers, the prognosis would be extremely poor, even if all the necessary interventions are administered at the appropriate time. So it's usually a three-pronged, option that we tend to give them. So I don't think the current laws, pose any significant challenges. Currently, what I would say though is if we're just looking at cardiac lesions in isolation, there may be some technicalities in terms of whether or not these lesions or some of these lesions in themselves are incompatible with life and therefore, would fit into that legal framework that we have currently.
All right, thank you, Doc. And Dr. Hunter, in the advent of changes to the regulatory framework in the US with Roe versus Wade, I don't know if that's affecting you and your management of patients in any way. I know it's a state thing. I don't know if you maybe.
Right. No, I do work in Florida, and yes, termination is not illegal beyond 15 weeks of gestation, which is good in my part because, I believe in God and I'm a Christian. So, I do believe God's word when it says that he did form me, before he knew me, he formed me. He did knit me together. He knew he knit me together, my inward parts while I was in the womb. You know what I mean? So in terms of moving forward and providing care, the being unable to terminate, it doesn't mean that we cannot do anything for the family. And in fact, I think operating under the framework that's given to us by God according to his standards, right? In terms of, which is a whole nother discussion in terms of looking at, and ethics comes into that, having a standard for what's right and what's wrong, which we won't go into necessarily here, but just to leave it at operating under his framework, I believe there is a way to still move forward. Looking at our field of pediatric cardiology, there was a time when we were not able to offer pediatric cardiac surgery at all, and then our patients would demise. And then came the advent of open heart surgery in the 1940s and 50s. And even throughout the course of history in our field, we progressively became able to offer care to patients with more and more complex forms of heart disease in various settings.
In Jamaica, as Dr. Little has shown, we went from a phase where we were not able to offer any surgery locally to now where he's able to offer congenital heart surgery even to patients with tetralogy of Fallot. And yes, the resources necessary to manage these more complex patients, it is demanding, it is draining, especially in a resource limited setting, but there are options of allowing that child to continue through the gestation, providing the support that is necessary for the mom and family through to delivery, including if it just involves comfort care, enjoying as much time that you have with that baby until that baby passes. If the baby passes, and you're providing support to the family. Sometimes in rare or in less frequent circumstances, the babies may continue through to older age, and then you have a different scenario that you have to work with those families. But I wouldn't say that, the solution to that necessarily is termination, again, operating under the framework that we have in terms of guidance through God's word. But in our practice, especially now that it is illegal beyond 15 weeks of gestation, the options that are offered to the family, most lesions can be offered some form of corrective surgery or palliative surgery postnatally. For the circumstances where that is not possible, a severe hypoplast who has total anomalous pulmonary venous return is going to have a very poor outcome. If there are extracardiac anomalies that are going to complicate this, the outcomes for the patient, if there are associated chromosomal anomalies, even though for those patients with trisomy 18 and 13, there are more families now that are considering corrective surgery for simple lesions, especially, for example, VSDs, where we wouldn't do VSD repairs before. We do counsel that there's the option of just doing nothing at birth, allowing the baby to go and providing comfort care. There is a great need for support to the families who are delivered the news that the baby has congenital heart disease, as well as postnatally after the baby is born, supporting the family through the process of observing the care that is offered to the child and whatever the outcome may be for that child, whether it be towards palliative surgery and then continuing the care of the child through adulthood. There's a need there that Dr. Reid alluded to, as well as to those who allow the baby to pass in the postnatal period. And I don't think, even in the first world, I don't think we have yet mastered that. It takes a team, and we're still growing in the level of support that we're able to provide psychosocially, in addition to the medical aspects of the care for these patients.
All right, thanks, Dawn. You mentioned very briefly the resource poor status in some countries, namely perhaps Jamaica to some extent. So if this is suggested, do you think that we should be offering more services? We mentioned earlier in some of the presentations, and we all have this global perspective with experience that spans many countries and many continents. And somebody also mentioned stuff like private-public partnerships. Should we be offering more outsourcing genetic testing, screening? I know we do some here, but should we be trying or aggressively pursuing the outsourcing of screening or overseas delivery options, genetic counseling as such?
I agree with Dr. Little. We have a long ways to go with the disease that we have existing, just basic things, basic aspect of the care of the patient with congenital heart disease, including our simpler lesions. Yes, as we have, we're training more physicians are going overseas, to subspecialize and who have the desire to return home to improve the care offered to the families. I think we may get to the point where, okay, now in a first world setting, yes, genetic counseling is part of the routine screening, and there are different levels of testing that can be performed in utero as well as postnatally in order to, determine the genetic diagnosis. But especially where resources are limited, we often restrict to what's going to change the counseling or the management for this patient clinically. So yes, where it will impact on the management, we think there's maybe a chromosomal aneuploidy for sure. And then those patients can be picked up with a karyotype, you know. Fish will pick up a patient with DeGeorge syndrome. Going into whole exome sequencing, looking for the specific mutation associated with a particular congenital heart defect that right now is not going to change what we do with the patient, you know, probably we don't need to spend our resources there. But yes, with the knowledge that we have obtained, we have a responsibility to use it wisely and constructively towards improving the care of our patients. So I don't think the answer is to, okay, well, let's not progress because we can't do anything more, but let's see how we can use the information that we have to improve the care to the patients we have currently and to press forward.
All right, thank you. And just one last question, and anybody can feel free to answer this one. It's really about the rights of the parents and what is the approach when they disagree with the suggestions, advice from medical personnel? Dr. Little. I see this one.
That is a challenging one. That is a challenging one because you have to balance the rights of the child, the infant, with the rights of the parents and their autonomy over the child. You know, I think education is important, and we have to do our best to educate the families and that kind of stuff in terms of what we think is best for the child. Now, where that locks horns with traditional medicine or traditional knowledge, then there may be a role for an intervention because you're looking at the best interests of the child. Fortunately, I haven't had to do this very often, but there are cases where we have had to do so. I think just recently there was a patient at our hospital who had a PDA, something as simple as a PDA. But the parents did not want intervention at all. And so this was a child who was coming into hospital, you know, frequent infections, that kind of stuff. And this is something that's easily correctable, obviously. And so we had to take control of the child in terms of care of the child, and child got their surgery and is fine. But, you know, in something as clear cut as that, then I think, you know, we have to be prepared to step in. You know, if you look at the other extreme where we have very complex patients with single ventral physiologies, I think, you know, the approach is going to be a little more difficult. But for very simple things, I think as a physician, you have to stand up for the rights of the child, even if it may intersect or lock horns with the parents.
Okay. All right. Thanks. So thank you. Oh, we've not quite finished, but I do want to, at this point, introduce and invite consultant pediatrician at Cornwall Regional Hospital, Dr. Henny Harry. She, as I mentioned, is a consultant pediatrician at Cornwall Regional Hospital. She has a master's in neonatology from the University of Southampton, and she is passionate about neonatology. She will be presenting our 2 case studies for further discussion. So Dr. Henny Harry, over to you now.
Thank you so much, Dr. Monthrope, and thank you to our distinguished panelists. We are so grateful that you guys had signed up for this and that you are here to discuss this very important topic. Now, I'm just going to give you a brief summary of 2 cases, very, very briefly. So the first case is was a full-term infant with normal antenatal period. A normal scan was said to be done, and that was also found to be normal with a normal neonatal period. Now, as Dr. Walker said earlier, we're not sure who did the anomaly scan. There are a lot of persons doing anomaly scan who may not be experienced. However, she presented to the medical attention at about 6 weeks old because the child was failing to thrive. When she was seen, the child was found to be in significant congestive cardiac failure, and the baby was sent for further investigation. At 7 weeks old, baby had an echocardiogram, and this showed a double outlet right ventricle, transposed great arteries, moderate pulmonary valve stenosis, dynamic muscular subvalve pulmonary stenosis, complete unbalanced atrioventricular septal defect with a very small left ventricle, single competent atrioventricular valve, and a small PDA could not be ruled out. That was what was written. Currently, this child is about 2 years old, still failing to thrive, still has congestive cardiac failure, and still awaiting surgical intervention. Of course, this brings up some of the things that we have been discussing so far. And so I'd like to first ask Dr. Walker, could these lesions have been picked up? I think we've answered some of them already, but I'm going to ask it again since it was a patient here in our setting. But if the patient had the proper assessment, could these lesions have been picked up antenatally based on the available equipment and expertise that we have here locally?
Well, certainly the simple answer is yes. A lot of those lesions, certainly not all of them, but a lot of them that were listed could have been detected antenatally. You mentioned that the patient had a very large atrioventricular septal defect, which is certainly something which could have been visualized quite easily on the 4-chamber view. Some of the other aspects of the anomalies that we're seeing may be a little bit more difficult. So the transposed vessels, those things do require additional views to visualize, outlet views, and sometimes 3-vessel tracheal views to actually see. But certainly, at the time of the anatomy scan, one would have hoped that on visualizing that 4-chamber view, you would have seen that significant abnormality and then referred the patient to a specialist center where the patient can get a high-level ultrasound done to actually look for any additional cardiac lesions as well as any extra cardiac abnormalities. So that is usually the thing that we hope for those very obvious lesions to be visualized and then the patient subsequently referred.
Thanks very much, Dr. Walker. So that brings me then to Dr. Hunter. As a cardiologist, do you do fetal echocardiogram? And if so, would you have been able to pick up these lesions antenatally with as a cardiologist doing fetal echocardiogram?
Sure. So, barring any other factors that may limit the image quality, for sure we would be able to pick up that there was an unbalanced atrioventricular septal defect and then the malposed great arteries. So yes, the lesion would have been able to have been picked up by detailed fetal echocardiogram antenatally.
Okay, thank you. Just so back to Dr. Walker. So in this case, if these lesions were picked up antenatally for this particular case, is very complex. I think you would have said some of the things before, but what would you be offering this particular patient? Would you have said, this is the patient that you're advising, possible termination? Would you have said that we have help available, carry on, 39 weeks or whatever delivery? What would you be advising our patients generally, just practically?
Well, usually what we do is initially, as I mentioned, when we see these patients, we often do a detailed anatomy survey so we can get an actual complete picture in terms of not just the cardiac defects, but any other extra cardiac abnormalities. And that is usually the first step. And following that, we often have a multidisciplinary team meeting, usually involving our colleagues from the pediatric departments and specialists. So we can have a complete discussion, including with the patient, to discuss options. And usually the type of options that we present to the patient is based on the resources that we have available, prognosis, what are the chances of survival. So for some very specific lesions, we would discuss the possibility of medical terminations as one of the options. But we often tell patients, listen, this is only one of the options. The other option is we'll continue to monitor with the view, if it's possible, performing surgery in the postpartum period. And that is where now the coordination with the pediatric cardiothoracic surgeons, with Bustamante Hospital, with pediatric department at Victoria Jubilee in terms of organizing that early delivery. Certainly the other option would be we'll have to continue to monitor, to do serial ultrasound, serial growth scans, serial Doppler surveillances. Because again, as I mentioned, these babies are at increased risk of intrauterine growth restriction. And this is something that we would need to monitor because we may not be able to deliver at full term. We may have to deliver preterm if there's any obvious evidence of Doppler velocimetry abnormalities. Certainly we discussed with them that if we're able to deliver at term, that is also ideal. And that would also provide the best prognosis for babies, should it be deemed that these things are things that we can correct to improve the quality of life and improve survivability.
So Walker, and that is what is interesting, is that this child is 2 years old. So you would have, may have offered based on what is there, possible termination, but here's this mommy still have this child who's 2 years old, talking about, talking to her and so on. Of course, still failing to thrive. So that brings me to Dr. Little. So
a quick thing though, well, maybe I should let you ask Dr. Little, but just to say that in terms of the anatomy you described, there are lots of factors involved in determining the postnatal course, and just taking the anatomy as you basically described, with pulmonary stenosis in the setting of a patient who has single ventricle physiology and has transposed great arteries such that, perhaps the aorta is oriented to the larger right ventricle, so there's no systemic outflow obstruction, but there's pulmonary stenosis to limit the pulmonary blood flow. Maybe not as much as you'd like since the patient has heart failure, but it may be one who may not have needed a neonatal intervention per se, but who could have gotten maybe a Glenn, at 3 to 6 months of age and then continued along the palliation pathway. But, even in the counseling, having an accurate diagnosis, as accurate as we can in the fetal period, is important. And sometimes we try to be 100%. Sometimes we get close, but sometimes there's a few unknowns that we're very transparent about with the families, and explaining to them the spectrum of possibilities.
Okay, thanks, Dr. Hunter. So Dr. Little, the question comes to you now. Are we able to offer anything based on the lesion that was described? Are we able to offer this patient any form of intervention locally? If not, what do we tell the patient?
I have to watch my words carefully here. So as Dr. Hunter indicated, this is a patient who is a functional single ventricle, but without any apparent outflow obstruction in terms of at the aortic valve level, or the arch apparently is okay as well. This is a patient who potentially could have a Glenn, bidirectional Glenn. However, it is important to find out what this patient's pulmonary pressures are, because the child is now 2 years old. Although the pulmonary stenosis is moderate and there's a chorea of a PD, we don't know if this patient has been over-circulated for the last 2 years. So even before discussing surgical intervention, I think this patient would need to be investigated with regards to what the pulmonary vascular resistance is, to see whether they would be a candidate for a bidirectional Glenn, because the pulmonary pressures would have to be low to tolerate a Glenn, the Glenn being done. And even in some of these patients, even a Glenn without going on to a Fontan may be adequate palliation in our setting. So we don't necessarily always have to go through to a Fontan, but even a Glenn may provide the patient with a bit more oxygenation than they have currently. So I would say that there is a possibility of intervention here. Fortunately, this patient didn't require a Norwood at birth, but would need some investigation to find out whether they are still a candidate at this stage for a bidirectional Glenn.
Thank you, Dr. Little. I'm going to hold the second case because I think we're going to be discussing the same things in terms of, what is available and what could have been done. So I'm going to send it back over to you, Dr. Montrose. Thank you.
I want to say, but I don't know if I should say.
Yes,
but,
go ahead, Doctor.
no, and I know we won't discuss the second case in detail, but you know.
Oh, would you like me to go ahead and,
you know, I mean,
the summary? I could do it. I just thought that maybe we're gonna have to say, but I'm gonna go ahead and do it. So the second case is an antenatally, the anomaly scan was done in this case, and it showed hyperplastic left heart. Otherwise, the antenatal period was otherwise uneventful. So this patient was diagnosed antenatally, and therefore she had an echocardiogram done within the first 24 hours of life. This echocardiogram showed tricuspid atresia with transposed great vessels, a rudimentary right ventricle, large atrial septal defect, small ventricular septal defect, interrupted hyperplastic aortic arch, and a patent ductus arteriosus. Again, we have another child. She's now 3 years old with congestive heart failure, still failing to thrive, and she's also awaiting surgical intervention. So the questions would have been similar in terms of, you know, is there anything that we can do for this child? And having found a hyperplastic left heart antenatally, it's the same thing, you know, what are you going to offer to her? She needs to go overseas to deliver, since you might not have been able to help her the postnatal period, because here we have, she's 3 years old. So it's not, as I said, can we really tell patients that their lesion is incompatible with life? As in this case, we were told comfort care, but here she is, she's 3 years old. So Dr. Monte, can go ahead and say what you wanted to say about it.
Yeah.
Little is able to say, are we able to offer anything to this particular patient with these lesions?
Well,
you want to go ahead first, Juanita?
While you frame your response.
No, I have framed my response already, you know.
No, well, this is a more complicated.
I have it all drawn out here already.
Okay.
More complex, of course, right? Because this one has systemic outflow obstruction. So triatresia with a restrictive VSD, triatresia with transposed great arteries with a restrictive VSD, and therefore a hypoplastic ascending aorta and arch interruption. So this patient would require a systemic outflow reconstruction, like, you know, a Damas-Case stancil where we anastomose the aorta to the pulmonary artery to ensure unobstructed systemic flow, and then continue with the Glenn and Fontan as part of the palliation. So, you know, this patient being 3 years old would need, just as the prior patient, a cardiac catheterization to see what the pulmonary vascular resistance and the pulmonary artery pressures are. I'm going to assume that they're elevated and that the PVR is elevated. Very high mortality for any intervention with this child at this stage. And even, I mean, now, well, let's go back and rewind. In the fetal period, yes, perhaps we could have counseled the family but this type of surgery. We're not offering Norwoods in Jamaica currently. You may want to explore an overseas option, you know, and then the centers overseas would have to review the case and see if it's a patient that they're willing to accept for intervention or not. It is miraculous that this patient is still surviving. I was going to share, it reminded me of a case that we have now, an adult patient who is in her early 30s, I believe, who came to us. She migrated to the United States, and she has an interrupted aortic arch and has been surviving with her large ductus open, supplying flow to her low extremities. And, you know, the question has come up, you know, whether or not we can offer intervention for her as well. But for now, I think the surgeons prefer to leave her as she is and allow her to live as long as she can on the current physiology, which may be, even though it's difficult in terms of quality of life now for this patient, you know, the only other thing that we could do reasonably is to do a cath, but then to what end? You know, if we're not going to do a Norwood in Jamaica, you know, would this even be a case that would be considered overseas and very difficult? It would be a miracle if there would be a center overseas that would consider in this scenario, just because of the likelihood of high mortality in this patient if you touch her surgically. It may just be a matter of improving her quality of life and allowing the family to enjoy whatever time they have with her as long as she lives, you know?
Thank you, Dr. Little.
I totally agree with Dr. Hunter. This patient, if addressed earlier, would have needed a very complex neonatal repair. in terms of artery construction, Demus K, and then a Glenn anastomosis later on. And we would need to know what the pulmonary pressures are. You know, wherever in the world we're talking about, whether this is Jamaica or in a first world setting, in the United States or in Europe, this is high-risk surgery. And as Dr. Hunter indicated, sometimes we have to advise our families that it's sometimes better, and for me, I think it's more tolerable to live with a child with congenital heart disease versus losing a child on the operating table. There is very little closure to a family when a patient dies, you know, after a complex operation. So sometimes you have to you know, have a balanced approach. And for patients such as this, in our setting, I would continue medical care. I would not recommend surgery in our setting. It would be very difficult to export this patient as well, just because of the high-risk nature of any kind of intervention.
I just want to mention one thing that I think one very important aspect in terms of care is accurate antenatal diagnosis. So that will certainly give us a lot of time to have these meetings to develop an appropriate plan and to institute some form of surgical intervention, if applicable, as early as possible to improve prognosis. So the importance of this antenatal screening or appropriate antenatal diagnosis is paramount.
The team approach. Thank you very much, Dr. Walker.
Very important.
Okay, over to you, Dr. Montreal. Thank you.
All right. Thank you, Dr. Henny. All right. So I just want to move over to our question and answer session. We have a few questions in the chat here, so maybe 3 or 4 questions. So if you want to stay there, Dr. Walker, the first question is actually directed to you, and they want to know, it's from Tristan Henry. They want to know if fetal echo is readily available.
Unfortunately, it's not. It's not something which is offered at very many centers. There's only a select few of individuals which are capable of doing fetal echocardiograms locally. And in terms of training, I don't think that there is any extensive training locally in fetal echocardiograms. Most of the training are in specialized centers overseas. So we tend to rely primarily on our routine ultrasounds, looking at these basically advanced cardiac views. So we're talking about 4-chamber views, the outflow tracks, the three-vessel tracheal views, and very limited use of our Doppler interrogations. But certainly I wouldn't say that there are many, if any, individuals experienced in very advanced fecal echocardiograms, looking at the valves, measuring the valvular waveforms, the valve pressures, and so on and so forth.
Okay. Thanks, Phil. And another question, this is from Dr. Gisnita Roberts. How do you handle a situation where the baby has cardiac pathology, which can be corrected surgically, but the parent or parents refuse on religious grounds, as the surgery may involve the utilization of blood products? So
that's probably Dr. Little.
Yeah, I think that one is yours.
I think there are strategies that can be utilized to minimize the use of blood products. So if it is that the family is refusing on the basis of that they don't believe that blood products should be utilized, I think there are ways to get around this. And I think I'd explore that with the families, because we have had patients before who, for whatever reason, the family is Jehovah's Witness or whatever, and we have been able to operate on these patients. With that said, with the most complex patients, it is very difficult to get through surgery without use of blood products. But if it's a very simple lesion, then I think that families can be reassured that surgery can be done without blood transfusion. Cardiac surgery can be done without blood transfusion.
Okay. All right. Thank you, Dr. Little. And the comment, and this comment would essentially, I'm going to try to summarize this. We'll put it based on some comments from Dr. Hunter earlier. And this is from one of our maternal fetal medicine specialists here, Dr. Tali Titus. And the comment is basically that termination being an option, and wanted to say that it is offered in certain persons outside of religious beliefs and whatnot. And I don't know if anyone can expound on that, you know, outside of religious beliefs, when is it options? I don't think we addressed it, our experience with when it is actually being offered. So I don't know if anybody can expound on that, like when it's offered and how that works, but it's been made mention of that it is an option, and you know, just remind us that it is an option in many situations.
Right. What I would say with respect to termination in terms of when exactly it is offered, it's not, you know, a hard and fast situation. It's very fluid in that a lot of lesions, which we did discuss, may not necessarily be, as I mentioned, incompatible with life. Life expectancy may be significantly reduced, morbidity may be significantly increased, but the lesion themselves in isolation are things which can be operated on, whether corrected or, as Dr. Little alluded to, some form of palliation care administered. So the lesion in isolation may not be incompatible with life, and therefore, if we're using the very strict framework, the legal framework that we have here in Jamaica, then those patients would not necessarily fulfill the criteria for termination. The problem is this, however, that a lot of these cardiac lesions, again, 50% may be associated with underlying aneuploidies, and these patients may have other extra cardiac abnormalities, CNS abnormalities, GI abnormalities in the limbs, abnormalities with respect to the lungs. So these are the things which will invariably worsen the prognosis and may lead us to have that discussion, re-termination. So the multiple abnormalities which are present, and not just the isolated cardiac abnormalities which are leading to us to make the decision or provide this option regarding termination. The other thing is dependent on the status. So if we're doing an anatomy scan and we're seeing these abnormalities, plus we're seeing things like significant oligohydramnios or anhydramnios, pulmonary hypoplasia. These are things which would obviously significantly reduce fetal prognosis. And therefore, these are the things that would explain to the patient or further justify termination as an option. But as I said, it's really only just one of the options that patients often have available, because patients may want to continue. The pregnancy will continue doing fetal ultrasounds, monitoring the pregnancy, and some may progress to term. Unfortunately, there's a large percentage who may have intrauterine demise, but you do have those which progress to term. And there is always that possibility, again, following discussion with our pediatric colleagues, of interventions being offered to improve prognosis or prolong survival.
Okay, thank you, Dr. Walker. And I believe our last comment is one I would have to probably dissect as perhaps an individual, and it may be addressed by our counseling, but maybe you could address it from the point of view as if anybody ever asks you, or parents ask you about support for pain, suffering, if the illness is going to give any significant pain to the child, or if they will be in significant pain, if the financial burden is going to be such that it would cause additional strife for the family, and of course the effect on the family as a whole if there are other children involved. I should ask, how do you approach that in terms of counseling, or if there are resources or support if they choose to go ahead? I mean, what would your approach be? Sounds like a lot of counseling and spiritual. Yeah.
Yeah, I mean, I don't think we, and I say we globally, have the right infrastructure to support these families. We have been more in tune with the psychosocial impact of the patient with congenital heart disease for that child, him or herself, as well as the impact on the family as a whole, because even in patients who go on to have palliative surgeries, you know, having a child who has significant congenital heart disease, who requires frequent doctor's appointments, follow-ups, maybe in and out of the hospital, it is a challenge for families. And so definitely there is need for, as much as we aim to provide excellent medical care to sustain life, supporting the patient psychosocially as well, and the family to endure through the process is a challenge. And there's still lots of room for growth in that regard. It's definitely a multidisciplinary team approach, okay, involving, you know, social workers, you know, psychology, and then Dr. Reed touched on the neurodevelopmental issues that come along the way for our patients. So we have been, even in my experience, a bit sparse on that side of the support offered to our families, even with robust clinical care. And it's an area where there's a lot of room for growth and making that aspect of our care that we provide to our patients more robust. Yeah, because it's not easy.
All right. Thank you, Doc. And one last comment from Dr. Blondell Crossdale. And this is, I guess, a note to all of us who are in the medical field. Referral to fetal maternal medicine clinics need to increase in higher risk mothers to improve pickup of some of these lesions and other abnormalities. So we can all bear that in mind. And I think we'll all agree with that comment as well. So this actually leads up to the end of our session, and I want to thank our panelists, Dr. Hunter, Dr. Little, and my apologies, Dr. Walker, I think I might have misnamed you as Leroy, Dr. Leo Walker. All right, so I want to thank you for an excellent question and answer session and a very in-depth discussion. And I do believe that we would have covered a lot of ethics here. We would have looked at decisions that have lifelong consequences for the pediatric patient. Of course, we'd have looked at issues pertaining to informed consent, balancing the benefits, risks and benefits of treatment, and of course, looking at what's in the best interest for the child. I think Dr. Little had mentioned that as well, protecting the child's autonomy and dignity. And of course, we'd have mentioned addressing the ethical dilemmas such as allocations in limited resource settings. So I think we did it was a very comprehensive job that you all did, and thank you very much for an excellent session. And at this point, I want to hand over formally to Dr. Antoinette Seeley, who I think will be bringing our vote of thanks. Thank you very much to our panelists. Thank you.
Thanks, good evening. Thanks, everyone.
Present in all things and grateful for all things. Maya Angelou. I'm Antoinette Seeley, a junior resident in the pediatric department at the Cornwall Regional Hospital, and today I stand in agreement with Maya Angelou because I am both honored and privileged to have been here today and now to express my gratitude to all of you. Let me first thank the Pediatric Department of the Cornwall Regional Hospital for once again pioneering this spectacular symposium. We are forever indebted to Dr. Juanita Hunter, our keynote speaker, for a well-articulated and informative review of critical cardiac pathology in neonates. Your interesting updates on and highlights of relevant cases will stay imprinted in our minds for a very long time. In the same vein, we also remain indebted to Dr. Sharon Forrester for keeping us in the fast lane with our response to cardiac emergencies, to Dr. Tamara Tomlinson for an always useful breakdown of ECGs, to Dr. Charmaine Scott for such a timely and current update on rheumatic fever, to Dr. Darren Reed for reminding us of the nuances related to our adolescent population, to Dr. Sherard Little for keeping us abreast of the advances in cardiac surgery in Jamaica, and to Dr. Leo Walker for forming a terrific team with Drs. Hunter and Little in walking us through ethical decision making with our critical cardiac lesions in our neonates. Now, the intricacies and the importance of the unique entity that is the pediatric cardiovascular system cannot be overstated. And so we want to thank each of our speakers today for empowering all of us to present better care for the pediatric hearts. Our moderators richly deserve our gratitude, and I offer same to Dr. Agre Sajabi, Dr. Coralie Antoine, and Dr. Patrice Moncrief. We also take this opportunity to thank our technological giants, Oldgate Solutions, ably led by Mr. Sam Heron, and to once again attempt to express the inexpressible gratitude we have for our sponsors, Indus Life Sciences, Nestle, and Abbott. Hats off to our indefatigable planning committee of Dr. Queen White, Dr. Terry Ann Johnson Harrison, Dr. Gail Lewis Mitchell, and Dr. Cecilia Henny Harry. Last but not least, we extend heartfelt thanks to all of our attendees. Thank you for your questions, your attention, your interaction, and your commitment to being here with us today. Once again, we extend our deepest gratitude to everyone who took the time to be here, and a further thank you for journeying with us all the way to the finale. Have an excellent Sunday, and I cannot wait to see you next year.